So Aries told me to come here, start a meeting, and after that, call him. But I cannot do this, Harris. Come here with me. I cannot open IBC meeting without you. I think this is a 1,000 hands process. It's not 4 hands, it's a 1,000 hands process. En español se habla que siempre el buen hijo a casa retorna en algún momento. That means in English that the good son always will be back home. And I think we are finishing here a process that we have started in some years ago, but really in the Congress of London. So took 2 years to could organize this meeting for you. I'm very happy because finally we did. I think IFSO is a big, important organization. IBC the same. We are working for the same thing. We have the same tasks. We have the same goals. We have a very similar way to work regarding the differences in both organizations. Every organization has his own style, but in the end, we are looking basically for the same. That is to improve the results. That means is, I think that the first goal is to have better outcomes for our patients. After that, we have educate our peers, our colleagues. Someone, always when I talk that we should educate, someone asks me, but where I have to start? I have to go to the television, to have a program on television, on the newspaper, and say something about obesity in a big media? No, you should start in your group. Just now. We have to start working in our circle, in our hospital, with the cardiologist, the pneumologist, with the administrator of the hospital, with our team, with the lady that will have the first contact with the patient when the patient goes to the hospital. So this is educating bariatric in metabolic surgery. And it's pretty easy if you really want to do it. So it's my pleasure to have back IBC in IFSO Congress. These are a tremendous effort of Harris and now the group that he has in IBC supporting him. Of course, we have Tom, that is very important in the organization. We have Manuel. You have different people in different parts of the world. So Harris, welcome again. And I'm sure we have a tremendous scientific high-level meeting in this symposium.
I'd firstly like to say a big thank you to IFSO and to Professor Almina Ramos and Antonio Torres for their tremendous support for this very kind invitation to set up this 5th IBC Symposium at the IFSO World Congress. We're really delighted to be back here and setting up meetings to help improve and question a lot of the aspects of bariatric surgery so we can improve care for our patients. I'd also like to thank everyone on the IBC committee. There's hundreds of people working behind the scenes Tom Rogula, the founder, has been instrumental. Ariel Ortiz, who unfortunately couldn't be here today. Gabriella, Cynthia, the list goes on. There's so many individuals who've contributed. I'd also like to thank all the speakers today who have given up their time. I know how busy you are, and I thank you so much for taking part and contributing to this meeting. And lastly, I'd like to thank all the delegates who've come to listen to the IBC, and I hope it will be the beginning of a very strong and successful relationship with IFSO and helping to, again, improve the care of patients. That's ultimately what our aim is. I'd just like to invite now the founder of IBC, Tom Rogula, to say a few words. Tom.
So we will never forget that IBC was born here in IFSO. We were and we are proud of IFSO. IFSO is our mother and father. I will never forget the first meeting of IBC in Hamburg when everything started very slowly and humbly, but finally we are all back again. So this is a historical moment when we are returning to IFSO somehow, but we never left IFSO, by the way. So what we did, we used that portion of IFSO which was about discussion, open forums. We make this a little bit separate, but finally we are back again. So again, thank you so much. I really appreciate all of the efforts that you did for us, and we hope we initiate collaborating again for better care of our patients. I want to introduce my very good friend, almost my sister, Professor Weiner, and she was one of the first who started IBC many years ago in Hamburg, and she's one of the mothers, I would say, or founders of the IBC. Sylvia.
So, thank you so much.
Let's do properly. Now I should introduce Sylvia Weiner.
Thank you so much also for coming up in the mornings. I think the IBC sessions are always, sorry Antonio, but I think they're always the best ones. But this is a very good congress as well. I mean, it's exceptional. My congratulations to that. And I'm very happy and I'm very proud to be here and always being in close contact with Harris. And I think we also use the opportunity to say thank you to you, and maybe we can ask you for a short word just to welcome the audience as well. I have to say just in advance, it's a tremendous work to set up a program like this. And I think Harris is working really, really hard. But thank you, Antonio, for giving us the opportunity. Maybe you just have a short opening word. Thank you so much.
So, well, as a president of the meeting, I'd like to thank, Harris and all his team, of course, Tom Regula, know that so many years ago, more year at Tom than Harris, but gonna be a pleasure. I think when Dr. Ramos, our president, we were talking about how to manage this issue of the meeting. As I said, a couple of times or more than two times, no, more than twice, that we would like to be inclusive. Inclusive means to be inclusive. So when we were discussing with Harris how to manage that, I think IBC deserves to be within the IFSO family. It's going to be a very important organization, and we can do a lot of things in the future together. I have to thank especially Harris, just for you, because you did an extraordinary job. Unbelievable, you were so pushing, so serious, so hard, and I think you did a extraordinary job. So you and all your team, but I can try to personalize on you the nice work that IBC did for this meeting. I thank you so much for being here, building up this extraordinary program. And I hope, all you guys we will enjoy the huge and the deeper discussion that we will have for sure early this morning. So thank you again.
So now we have to start because we want to be in time. So I will call up Professor Kadi Gawat from Egypt, and he's going to help me a little bit with the session instead of Amino because he's so busy, as you can imagine, that he will be hopping off a little bit. And Khalid is not only a tremendous photographer, but he's also a very good surgeon. He's doing a lot of surgeries, and we're very happy to moderate the first session. And if it's okay, then you call up Lillian.
Okay, so let's get started. I'm going to start with calling Lillian Koh, the IFSO president. She's going to present bariatric surgery in patients with cirrhosis and portal hypertension, pushing the envelope.
So today I've been asked to talk to you about bariatric surgery in patients with cirrhosis and hypertension and whether we can push the envelope. So I thought I'll start off with some definitions. Non-alcoholic fatty liver disease covers a spectrum of liver diseases, and this varies histologically. On one hand, we start with a benign condition which is classified just by pure steatosis, which is the accumulation of lipid in the hepatocytes, more than 5% of the liver weight. On the other extreme is NASH, non-alcoholic steatosis, and this is classified and defined by steatosis, but with necrosis, inflammation in the hepatocytes. It is this subset of condition that will give you a range of conditions such as fibrosis, cirrhosis, and later on, hepatocellular cancers and terminal liver failure. So let's define cirrhosis. It is a slowly progressing disease in which liver disease is replaced with scar tissue. It is reversible if the cause is removed. It prevents liver from functioning properly, and the scar tissue that blocks the flow of blood through the liver can slow the metabolism of nutrients, hormones, drugs, and naturally produced toxins. It can also, by preventing blood flow, result in portal hypertension. Now, cirrhosis and surgery has been associated with increased risk. It results in longest length of hospital stay. It results in a 30% post-operative mortality. This is 10 times compared to patients with no cirrhosis, and about an 11% increase in a 30-day mortality post-operatively. There are two ways of measuring cirrhosis. The Charles-Turcotte-Hughes cirrhosis, which is a score of A, B, C in terms of severity. It's been criticized because it uses 5 indicators. 3 are biochemical, 2 are subjective, which is the presence of ascites and encephalopathy. A more recent model, which is the model for end-stage liver failure score, is a formula using biochemical indicators. And as the MEL score increases, the risk of mortality increases as well. What about cirrhosis and bariatric surgery? Now, this is a summary, data on patients who underwent bariatric surgery using the nationwide inpatient sample in the USA. They collected about 700,000 patients, of which 388 had compensated cirrhosis, 62 in liver failure. What they found was if you have no cirrhosis, that is your control. If you have compensated cirrhosis, there is an increased hospital stay, about 3 times the increase of mortality rate. But once you have decompensated cirrhosis, your hospital stay increases significantly, as well as your risk of dying. Now, what is the cause of liver failure or cirrhosis? A Western diet has been associated with weight gain. So if you have a high caloric diet, excess fat, high sugar, have a terrible behaviors lifestyle, then you become obese, and you develop this non-alcoholic fatty liver disease. There is some genetic modifiers that have been identified, and in particular the genotype PNPLA3 genotype has found to be associated with a higher fat content and therefore a higher increase of inflammatory changes in the liver. This particular genotype is a membrane protein that is found both in the liver and in the adipose tissue. It participates in the breakdown of intracellular fat and is influenced by carbohydrate and lipid intake. And those with this genotype MM have an increased tendency for hepatic fat storage. So this is a study looking at the genotype MM, and it's found to be more prevalent in African Americans, Europeans, and more so in Hispanics. And this is a study looking at the various groups and the incidence of these conditions, and you can see that the Hispanic group has a higher risk of NASH and inflammation compared to Caucasians as well as the African American group. So it is a genetic predisposition. And this is to show you that if you have the MM gene and you combine it with obesity, there's a higher risk of your liver becoming cirrhotic. As I said earlier, cirrhosis can be reversible. So this is a study looking at weight loss and looking at the various groups. And in summary, by losing weight over a 52-year period, there is good resolution at the end when you've lost weight of these conditions. So what would be the treatment? Well, if you lose weight, bariatric surgery, you will reduce liver fat, and therefore you reduce your NASH progression. And prospective data has shown that there has been an improvement in all histological lesions of NASH, including fibrosis. I would put it to you that bariatric surgery is an option in patients who are unresponsive to lifestyle and pharmacotherapy. In a recent publication on guidelines by hepatology, of which there were 53 guidelines, guideline number 21 was that foregut bariatric surgery can be considered in otherwise eligible obese individuals with non-alcoholic fatty liver disease as well as NASH. They've even gone on to recommend that patients with compensated NASH or even cryptogenic cirrhosis be considered for bariatric surgery. And this is by our medical colleagues, the hepatologists. In a recent article by Phil Schauer, he asked that considerations for bariatric surgery be for patients with cirrhosis. In this paper, they stated 3 points. One is that bariatric surgery can be performed in patients with well-compensated cirrhosis, particularly Charles A. Patients need to be carefully selected and optimized, and bariatric surgery may provide the elixir for part of the armamentarium of therapeutic options for patients with cirrhosis. So what is the evidence? This is one of the earliest papers, a systematic review and meta-analysis on the effect of bariatric surgery. It's got 15 studies, over 750 paired liver biopsies, and what they found following bariatric surgery, that there was improvement in steatosis by 91%, steatohepatitis by 80%, fibrosis 65%. And this is a summary. There is an increasing correlation with ALP and ALT, which is one of the liver enzymes. It does not correlate with percentage of body fat, but it does correlate with the trunk limb fat ratio. And in the lower graphs, it correlates as well with the incidence of diabetes and hyperlipidemia. So cirrhosis goes hand in hand with abnormal liver enzymes as well as diabetes and high lipids in the blood. This is a more recent systematic review was published last year, 32 studies with bariatric surgery with liver histology, but none of these are randomized controlled trials. There were over 3,000 liver biopsies. Bariatric surgery induced weight loss, and you can see, again, a good resolution of steatosis, inflammation, and fibrosis in patients who had bariatric surgery and lost weight. This is a more recent systematic review of bariatric surgery, and in particular with cirrhosis. There's 9 studies altogether. Cirrhosis was confirmed on true-cut biopsy. 5.7 of these patients had portal hypertension. As you can see, again, good outcomes with the different operations. But what is to note is that the more complex the operation, going from adjustable gastric band to a BPD, the higher the mortality, the higher the rate of complications. These are an outcome of bariatric surgery is a range of the types of causes of cirrhosis. And what they found was that with time of surgery, there's a decrease in weight. And what they found was that in the post-op complications in this group of patients was higher, 17%. And these are the types of post-op complications that was encountered. Mortality was 0, which is good to know. And if you look at the various indicators of how well they did after follow-up of 1, 3, and 5 years after bariatric surgery, you'll see that all these indices improve significantly. What about portal hypertension? Now, this is a frequent sequelae of cirrhosis where fibrosis, scarring, and regenerating nodules result in an architectural distortion of the hepatocytes and therefore increasing portal hypertension. With the increase in portal pressures, it results in a number of complications such as splenomegaly, and these patients present with thrombocytopenia. There is a hyperkinetic circulatory state resulting in ascites, unstable hemodynamics, gastroesophageal varices, affects concomitantly the kidneys, the lungs, and higher portal pressures. It is a relatively contraindication for surgery because there's an increased risk of post-operative liver failure. So the mortality rate, if you look in general, just with cirrhosis is 14%, but it's almost double that if there's presence of portal hypertension. This is a study which looked at performing bariatric surgery in patients with both cirrhosis and portal hypertension. It is a retrospective study, but it is the largest study to date. Cirrhosis confirmed by biopsy, and what they found was that with careful monitoring of these patients, no patients died. It was a higher rate of a 30-day complication rate of 23%, but getting these patients through their surgery, there was good improvements in their diabetes, hyperlipidemia, and hypertension. Nevertheless, while they improved in their other comorbidities and they lost weight, there was no significant change in their liver enzymes nor in their MEL score, suggesting that perhaps these patients, their cirrhosis have gone beyond irreversibility. So in summary, 1 to 4% of patients undergoing bariatric surgery, you will encounter that they have incidental cirrhosis. We know that cirrhosis of the liver has a higher risk of complications. There is no level 1 evidence comparing bariatric surgery to surgical intervention for obese patients with cirrhosis. However, bariatric surgery can create a physiologic state of malnutrition, and there is a risk of liver decompensation. And finally, liver cirrhosis do result in a higher rate of mortality. So in my conclusion, bariatric surgery in patients with cirrhosis is associated with higher than usual risk of complications. If you're going to operate on them, you should be aware that in the incidental cirrhosis, you need to weigh out whether you are prepared to take on these patients with an increased risk of mortality. It appears in the literature that sleeve gastrectomies and gastric band may be the safest bariatric options for these patients. If you give them a more malnutritive surgery, such as BPD, you will have a higher risk of mortality. If you help them lose weight, there is a potential to halt and reverse their liver damage, and therefore I'll put it to you that bariatric surgery in highly selected cirrhotic patients can be relatively safe and effective. Thank you very much.
Thank you so much, Lillian, for presenting this data. And we can see we have really, really sick patients we are working on. And also the next talk will be coming up with a pattern which is very, very important. It's about the risk of patients in general they have about developing carcinomas. And I very welcome Mr. Bruno Skromo from the UK to get us an impact about this very, very important issue with the patient. Thank you so much.
Thank you very much. Thank you very much for, I'm very grateful for having the opportunity of talking at this symposium. So thanks to the International Bariatric Club, Harris, Tom, and IFSO, Professor Ramos and Torres. I consider myself a very lucky surgeon because I have the opportunity of doing both the bariatric surgery and also a resectional job. So I regularly do carry out esophagectomy and gastrectomy. And the number of technical skills and knowledge that these two specialties have kind of given me and my trainees, I think, are exceptional. So to discuss the risk of adenocarcinoma in the morbidly obese, I will be talking about the bariatric operations, the patient's profile, and the Barrett esophagus. I'll start with the bariatric operations. Because if we ask a cancer surgeon a very simple question, what is it that we want when we are thinking of doing an esophagectomy? It's very, very easy. We want a nice and healthy stomach. And the reason is because the greater curvature of the stomach is the best conduit that we have to reconstruct the intestinal continuity after an esophagectomy. There is one anastomosis. The operation is now done most of the time with the minimal invasive approach with laparoscopy and thoracoscopy. And the alternatives, such as colon and small bowel, are only used when the stomach is not viable. And it's for a very, very simple reason. It's because over the years, we have been able to reduce the complication rate and the mortality to a very acceptable level. Our oncological outcomes are pretty good, and the 5-year survival for cancer of the esophagus is approaching, well, it's just over 50% now. And the length of stay, especially with minimal invasive approach, it's steadily less than 10 days. The alternative is not so good, because when we have to use colon or small bowel, the technical complexity of the procedure it's much greater. And as you can imagine, the complications are higher. For example, for a colonic interposition, there is a need of at least 3 anastomoses. And these are the complication rate that are double, if not treble, in terms of anastomotic leaks, overall morbidity, mortality. And with the improving long-term outcome, we should not forget about the complication rate, in the long-term complication rate, because the colon dilates with time much more than the stomach, and patients are often plagued by symptoms of reflux and dysphagia, leading to a reoperation in up to 30% of the patients. So this is a way I fashion the gastric tube. I only need 3 centimeters of the stomach along the greater curvature. 3 centimeters is the minimal size. So it's not much of the stomach that is actually needed to fashion a gastric tube for an esophagectomy. So when we talk about bariatric operation, it's pretty easy, I'm afraid. The sleeve gastrectomy is not a good friend of the cancer surgeon, as the greater curvature is completely resected. The gastric bypass is certainly the best option because we shouldn't be any close to the greater curvature, With regards to the guanine anastomosis gastric bypass, we have to be careful not to be too close to the greater curvature. And this is how I've slightly modified my technique for the guanine anastomosis gastric bypass, simply measuring 3 centimeters, that is a fully open bowel grasp on the greater curvature. So with a very, very simple technical kind of change, we can consider the guanine anastomosis gastric bypass also a good option in patients who may unfortunately develop a gastroesophageal cancer. I'll move to the patient profile because the risk of adenocarcinoma of the esophagus is quite a complex process. There are patient unmodifiable factors leading to the progression of the Barrett to adenocarcinoma of the gastroesophageal junction and cancer. Age, for example. Cancer of the esophagus remain a cancer of the elderly, although over the last 15-20 years we have witnessed an incidence of cancers in the younger age. Sex, male, are certainly more common in having a cancer of the esophagus. Caucasians compared to other ethnicity, and also obviously is all based on genetic and epigenetic changes that happen in the morbidly obese. There are also some more modifiable risk factors that lead to the progression of Barrett to cancer of the esophagus. Obviously, I'm talking of the adenocarcinoma. Obesity contributes in various ways, sustaining this pro-inflammatory and cancerogenic status. Also reflux-dependent. Reflux of acid, bile, and both is a very well-established and known factor that leads to the progression of Barrett to adenocarcinoma. Alcohol, smoking, diet, and the PPI used. Now, the PPI use, I think is a very important one because we shouldn't be reassured by the use of the PPIs as a way of inducing a regression of Barrett or preventing cancer of the esophagus. Because although the PPIs are the most commonly prescribed drug in the Western world, this hasn't been able to stop at all the increasing incidence of adenocarcinoma of the GOJ and the distal esophagus. What about Barrett? I think that when we start talking about Barrett, things are unfortunately gets a little bit more complicated. The reason is because there are more differences than actually in the definitions than agreements. The definition is different worldwide, for example, and the presence of intestinal metaplasia is not always considered essential. And this leads to different surveillance programs. We have one in the States, one in the UK and Europe. We have one for Asian Pacific patients. And as a consequence, if you look at the best papers published in the literature, what you will see is that there is a poor adherence to the Prague classification and the Seattle biopsy protocol. So we are comparing big numbers, but very different protocols, leading to a different pathological assessment, of course. And just to let you know, in the UK, for example, the pathological assessment has to be completed by 2 independent pathologists. That means that for a 5-centimeter Barrett esophagus, you have to take 20 biopsies, and these 20 biopsies to be looked after by 2 independent pathologists. That leads to lots of pros, but also several cons. It certainly allowed early diagnosis and early diagnosis of early cancers, leading to endoscopic resection and a reduction in the overall mortality. But as the prevalence of Barrett is high in the population, the yield of a surveillance program is low. Hence, it becomes very expensive and is not widely used. So to summarize my views on Barrett, I would say that the progression of Barrett to adenocarcinoma is highly variable. There are adenocarcinoma that develop very quickly in Barrett esophagus, so within the surveillance, are diagnosed at an advanced stage. Adenocarcinoma can develop in short Barrett esophagus. Long Barrett that are well described that do not progress to adenocarcinoma. And probably it's because the progression from Barrett to dysplasia to cancer doesn't follow the usual path as for colonic polyps. So we don't know enough, and we should be very, very cautious. So I've come up to my conclusions. And I think that every patient should have an upper GI endoscopy before any bariatric procedure. I think also that sleeve gastrectomy should be contraindicated in patients with non-Barrett esophagus because of the risk of progression, and also because by removing the greater curvature of the stomach, you condemn this patient to an alternative reconstruction that has a much higher complication, mortality rate, and long-term functional problems. You should also, I think that every patient who undergoes a sleeve gastrectomy should be carefully informed and consent of the risk of acid reflux, Barrett, and the progression to cancer. On the other hand, I would say that there are clearly groups of patients who are higher risk, such as the obese Caucasian male over the 50 years of age, and others who are a much lower risk, such as the obese non-Caucasian female less than 50 years of age. I would also say that after a sleeve gastrectomy, we should have a low threshold for carrying out gastroscopies, because the moment we lose the capacity aspect of the stomach, the whole fundus is removed, the symptoms of reflux after a sleeve may not be typical of regurgitation and heartburn. And also biliary reflux may produce different symptoms to acid. The frequency of the endoscopic surveillance, I don't think everybody knows how often should be done in a patient after a sleeve with non-Barrett. But in the future, I think that the use of a cytosponge, it will become a widely adopted alternative to an endoscopy. And considering the number of bariatric procedures that are carried out, or sleeve gastrectomy carried out worldwide, it will be a very, very useful tool. And again, once more, I would invite everyone not to be reassured by the use of PPIs. PPIs will control symptoms quite well if they are sustained by acid, but has made no difference at all in the incidence of adenocarcinoma of the gastroesophageal junction and the lower esophagus over the last 20 years. Thank you very much.
Thank you. Thank you very much. That was enlightening. And we move to Professor Scott Chikora from Boston. He's the president-elect of the IFSO, editor of Obesity Surgery, in another eye-opening presentation of his, Conflicts of Interest in Bariatric Surgery, How the Truth Sometimes Gets Distorted.
Thank you very much, Khaled. I want to thank Harris and Tom for inviting me yet again to be part of this wonderful club, almost a society in amongst itself, and it's great to be here. If you can get my slides up. This was a very humorous topic to be given to me because we actually wrestled with the concept of a conflict of interest in my own relationship with both the Obesity Surgery Journal and IFSO as an officer. So actually, I've been living in real time for the past several weeks. Okay, these are my cases that really don't have any bearing on this presentation. So I want to talk about and my disclosures, which you have to do as part of the conflict of interest. So what is a conflict of interest? It's a situation in which a person or organization is involved in multiple interests. For instance, somebody who is a surgeon, that's their principal interest to their company, to their hospital, to their patients, but is also, let's say, a consultant to a device company who's paying them. So it's any situation in which an individual or corporation, because it doesn't have to just be an individual, is in the position to exploit that position for their own benefit. For instance, I work for Medtronic as a consultant. I get a consulting fee, and for that I do a service for them, but that's not my normal position. My normal position is working in a department of surgery of a hospital. And there's primary interest, which is your primary position or job, and then there's the secondary interest, which is, let's say, your consulting position. Now, the problem is that even if we're totally honest, there's something called that perception of a problem, or that perception of conflict. Because as we all know the old saying, perception is reality. And if you look at it, there are outside influences on all of us, personal income, financial pressures to be a consultant, the academic advancements you get by writing the papers on behalf of your secondary interests, like you're working on a device with a device company and you're publishing papers on it, well, that benefits you academically. Then there's the enticement of fame and fortune. For instance, when the robot first came out, the early users of the robot became the experts, and now they're going all over the world teaching the rest of us how to do robots. So they have become famous in our field because they were early users. So these are all outside influences that could develop a conflict. And the outside activities could be anything. I mentioned consulting as an example. It could be serving on a board of directors. It could be acting as a paid witness, an expert witness in law cases. It could also be something like talks paid for by a pharmaceutical or device company when you speak on their behalf. Now, I'm not saying these are wrong. I'm not saying they're unethical. I'm not saying they're immoral. I've worked in a number of companies during my career, but it's that perception that you could be benefiting inappropriately, which is what we call this conflict of interest. And it doesn't have to be money, it could be stock options, ownership in the company, and it doesn't necessarily have to be only you. It involves your immediate family as well. So anyway, when we talk about conflict of interest, how do we prevent from having that perception that we're doing something that's incorrect? Well, it's we sign a yearly disclosure that states, here is what I'm telling the world I do. Here are the companies I work with, and therefore you know now everything that you need to know about me. You can make your own judgment about me. You could determine whether you think it's all straight and perfect or whether there are any issues related to that. So let me give you a few examples. I'm the editor-in-chief of IBC Surgery, but I'm also a paid consultant to Company X. I get a manuscript written about the product made by Company X, and I push it through and I get it approved for publication without much of a review. That's a conflict of interest. I did something immoral. Or the vice versa of that. There's a company Y, they send a paper to obesity surgery and I reject it right away. I don't even let anybody review it, I just reject it. I'm favoring my secondary interest. That's a conflict of interest. Another example, this isn't Dr. Regula, but Thomas is an associate editor of Obesity Surgery, a world-renowned robotic surgeon who is also a consultant to a vendor who makes and sells robots. So once again, despite poor reviews, Thomas quickly accepts the publication from his group, the company he's working with, so that it promotes their product. Again, a conflict of interest. And the last one, that there's a person out there who's the principal investigator of an industry-funded research study, seeing that the data demonstrates only a small benefit of the product that they're making, or in this case, the drug, but the PI has stock options in that company. So she neglects to include all the data into her papers that would make the product look, although honest, less effective. Conflict of interest. So let me give you another example and sort of map it out for you. So this is Dr. X, paid consultant for industry A, and is given an honoraria for speaking, for writing papers, and stock options in the company, so he has ownership. I don't know if I can point. So in any event, industry A makes a product B. And Dr. X is also happens to be an associate editor of Obesity Surgery. So now in Dr. X's hospital, he could evaluate the product and he could push the hospital to purchase that product. That could be a conflict of interest because he has ownership in that company. And the same thing is that he could be invited to give a talk about the technology but he could really bias the talk on the benefit of that company that makes the product that he has ownership in. I hope you could follow that. So let's look at a couple things. So here's an example of where Dr. X's behavior is inappropriate. He supports the purchase of the product by his hospital, even though it may not be the best product or the most cost-effective. He discusses the benefits of product B when he gives his presentations, but he's really not honest about it. He's sort of jury-picking which information he's presenting to make the product look better than it is. He doesn't disclose this as a conflict of interest on any of the paperwork. And remember here, he's an associate editor of the journal, so he manipulates the publication of manuscripts favorable to his product and rejects those that are not favorable or favorable to his competition. Well, here's another example. This is what Dr. X should be doing if he's following the confidentiality rules and these conflict of interest. He recuses himself from any discussion about the product with the people of his hospital who do purchasing. And he tells them up front, I can't be part of this because I'm with the company that makes that product. When he presents at meetings, even if he discusses the product or the device, he does it in such a way that it only talks about the science, and he keeps out anything else that may be construed as bias. And lastly, as his role as an editor of the journal, he's upright and forthright that the papers are accepted on their merit, and if the paper is too close to home, he doesn't review it or doesn't involve himself in the process, he steps back. And that's exactly what I do with obesity surgery. Any paper that I'm a co-author on, as soon as it hits the journal, I never see it again. It's managed by other editors so that I have no bias and no say in what happens to those papers. And remember, perception is reality. You could be viewed as having inappropriate behavior if you're not willing to sign these documents and be forthright about your relationships with outside interests. So what do you need to declare? You need to declare all relationships and let the reader or let the person that wants to collect that information make the decision themselves to say whether you're too close to the outside interest or not. The amount of compensation and the type of compensation and who receives it. Remember, it counts for family as well, not just you. And this is just a laundry list of the different things that you need to declare when you're declaring conflict of interest. How do you resolve a conflict of interest? Well, you can alter the topic, that's the focus, on the product or the service of the commercial interest, so it doesn't appear that there's a bias. You can alter the topic altogether, or if you're presenting, you could stick just to the science and don't get into the nitty-gritty of one device or product over another. And that normally will resolve the conflict. Now, what's very interesting is what goes on in the publishing world. Most journals require the authors to fill out confidentiality and conflict of interest documents, but they don't require their editors to do it, which I thought was very interesting. Nearly 100% of the top journals will send you a document to fill out when you submit a paper, but their editors are not filling out the same document, and that's wrong. In obesity surgery, and I believe in SWORD, editors must fill out the COIs just as much as the authors. And the problem is that relationships with these companies can be quite lucrative. 6 editors in America received payments from industry between $300,000 and $11 million for their relationships with industry. That is the potential for tremendous conflict of interest, or at least the appearance of it. So that's why it's so important to sign these disclosures to say, yes, I have a relationship with a company, but I'm going to separate church and state. My work with the company will not affect my relationship with IFSO or ASMBS or whatever else I'm working with. In the US, that's by definition now, we must disclose all money we get from industry, something called the US Sunshine Act. And I found that second statistic to be quite interesting, that 32% of oncologists in the United States publishing in high-impact journals have failed to complete the disclosure. In any event, just to round out this presentation, I just want to show you that there are rules of the road for several of the organizations we're members of. The ACGME is in the United States, is the body that regulates fellowship, training, etc. And you must fill out a conflict of interest report for all activities and all CME activities that you have with and without that company. ASMBS has a very solid policy. It's on their website if anybody's interested. And it applies not only to members, but it applies to the executive council and integrated health folks, the committee chairs, and the paid executive director of the society. And it covers all educational endeavors, including the journal. And this is just to show you that when you go on, there's a number of documents to fill out, and you're making a number of disclosures, and everybody must disclose. Now, there's also, this was presented by Jane Buchwald a couple of days ago, there's the International Committee of Medical Journal Editors, which regulates a lot of what goes behind the scene of a journal, and they too have a 3-page conflict of interest document that every author, and in the case of our journal, every editor must sign, and this is on the website. So when you download a paper to obesity surgery, you will be asked to download this document, sign it, and every author must send it back. So in conclusion, many successful bariatric clinicians of all breeds, of all specialties, find themselves with the potential conflicts of interest because, hey, look, we all want to make a little extra money. We have an expertise that's wanted out in the community. There's no harm in working with them as long as you're doing it with a full disclosure to your primary interest that you are in a relationship with an outside vendor, you are getting paid for it, but that you will properly behave, you'll honestly declare. Thank you very much.
Thank you, Professor Sikora, for this wonderful speech. It's very important that we watch these things, and it's a real honor for me to introduce Professor John Dixon in order to talk about the deficiencies of publishing randomized controlled trials. It's a very important thing. And for the younger of you, maybe you don't know it, but he's not a surgeon. He's an internal medicine guy who was always very close to surgery and helping us, but in the last years to respectfully judge our own work as a surgeon. It's a pleasure to have you here. Thank you, John.
Thank you very much. My slides? Oh, there they are. Oops. Go back. I'll look at these. I'll look down here, not on there. So I'm going to talk about the deficiencies of the potential deficiencies of the randomized trials that have been really led to the evolvement of metabolic surgery, and particularly focus on that BMI range that they've looked at, and that's a BMI range less than 35. So you can see my conflicts there. They involve drugs, diets, and surgical, and of course where I get money from research. And I always put this up. Everything we know about obesity is wrong, and we've made a lot of attempts to injure our patients, and I'll be talking about that later today. The crux of my discussion this morning is we have major limitations with regard to understanding the risks of diabetes. None of our studies, not one of our randomized controlled trials, has shown any evidence of long-term outcomes, in particular mortality. The problem is that current therapies for type 2 diabetes are extraordinarily effective. The weight loss, and yes, weight loss, in people with a BMI less than 35, the effect of weight loss is unknown. In fact, there may be risks. We have therapies that can mimic bariatric metabolic surgery in those living with type 2 diabetes, and the emerging therapies are very exciting, and we see that they are actually saving lives. So when we look at type 2 diabetes today, we have a lot of reasons why there's an increased number with type 2 diabetes, but in fact, one of the major factors in developed countries is the improved survival of people with type 2 diabetes. If we look here, this is Taiwan. The difference in the number of people with diabetes in Taiwan, prevalence and incidence in Taiwan, look at the prevalence is up the top. The prevalence between 1999 and 2004 went up enormously in both men and women. But if we look at incident type 2 diabetes in Taiwan between 1999 and 2004, it went down. When the incidence goes down and the prevalence goes up, people are living longer. So when we look at mortality, this is from Australia database, the Diabetes Registry, we look at mortality in men and women over that time period. You'll see 1997 to 2010. Look at that plummeting down. And then look at the socioeconomic factors. If we actually take the richest group, they're better off with their diabetes than the rest of the community. It's quite extraordinary, and we've got more data on that. So it is important to understand that we're winning with mortality. And where do these improvements come from? Standard of care, we look after our people with type 2 diabetes, quite a contrast to how we look after people with clinically severe obesity and risks. Pharmacotherapy, we've seen reductions in all of the complications. So today, when you're looking at a health outcome study, which is going to look at death and MACE and all of the proper things that we should look at for our new treatments, we have a really hard task to show improvement. And of course, the targets we're looking for, all of those are really very much achievable. Two of those are best achieved with medical therapies. We have a tool for hyperglycemia that's exceptional. Now, when we look at mortality and BMI, and let me really emphasize, BMI is a fantastic metric. It tells us how fat we are. It also has an association with mortality, and you're going to see there that the lowest mortality is indeed in the group. You'll see the blue bars are the whole community, and the red bars are the elderly, the people over the age of 65. Now, what you'll find there is that the lowest mortality is in the overweight and class 1 obese range for adults in the world today. Very important. Numerous studies show this. So we're actually taking people in the class 1 obesity and potentially putting them at risk if they lose weight. And in fact, the area where mortality and BMI really takes off is the area above a BMI of 35. That's where it takes off. Now, what about BMI and mortality when you're diagnosed with type 2 diabetes? Well, these are 5 longitudinal studies from around the world, 260 to 2,625 participants, 227,000 patient years, and again we see clear mortality advantage in the overweight and the obese compared to normal weight. These are people diagnosed incident type 2 diabetes. This is data from Sweden, looking at their national diabetes registry, and we look at the mortality associated with diabetes compared to those without diabetes. And if you look at panel A, the first 5 years, mortality in the first 5 years is the open box, and the mortality after 5 years is the diamond, the black diamond, you'll see that there's the people in the first 5 years, the whole group is up the top, the people in the first 5 years actually diagnosed with diabetes have less likelihood of dying. It's only after 5 years that it actually comes up at all, and in fact, barely comes up at all for those until you get to a BMI over 35, and particular over 40. Now, of course, that's the range where all our data is. That's the range where all of our mortality data in bariatric surgery is, over a BMI of 35 and largely up near 40. This is another interesting data set. This was pioglitazone study, 5,000 patients, a typical drug company study, and you'll see here that the lowest mortality in these people, this included the cases and controls, the lowest mortality was, oh, there it is, BMI 30 to 35. But more than that, weight loss during the study increased mortality, weight gain did not. Can intentional weight loss save lives? We know this data backwards, these numerous studies from bariatric metabolic surgery, but we must reflect that all of these, none of these were randomised trials, and indeed none of these included people with a BMI 30 to 35, except the Swedish obese subject study that included a handful with BMI above 34. So when we look at any other evidence, the only other evidence we have that weight loss might help us is with this LEADER study, a typical MACE health outcome study, and it certainly did reduce outcomes. There was a 13% reduction in primary hazard ratio for the outcome, the secondary outcomes low again. And just before I show you the graph of the data, you'll see there the weight loss for this study was 2.3 kilograms. Hardly a weight loss study. Here's the outcomes of the LEADER style for liraglutide, improved outcomes right across the board. We can't show this. We cannot show this with bariatric surgery. It's never been shown. So in conclusion, BMI below 35 with type 2 diabetes is associated with very modest overall risk of mortality, very modest. The benefits of weight loss and mortality over the longer term are not known. There's plenty of evidence that the BMI range 25 to 35 is the safest for the general community and the safest those living with type 2 diabetes. Established and emerging therapies have excellent risk factor control and are saving lives globally. We currently have metabolic bariatric surgery approved for use in class 1 obesity without any risk of overall long-term benefit versus harm. BMI is a good metric. It's a good metric for measuring fatness. It's actually near perfect. And we must respect it in the epidemiological terms. We have to also understand that intentional weight loss at this BMI range may have absolutely no effect on mortality risk. The likelihood is that we think it might have a mortality benefit. We also have clear evidence that it might have a mortality risk. So let me say, we need, before we have any credible evidence for doing bariatric metabolic surgery in a BMI under 35, we must have large randomized cardiovascular outcomes trials. They have to be done. We have to get our act together because this treatment shouldn't have been indicated. I'm being critical, but shouldn't have been indicated for the range that it has been. And if I were, and I was part of the team that put that together, but all along I've known that this data exists and it's problematic. Not something you wanted to hear, but it's real. Thank you.
Thank you, Professor Dixon, for that nice talk, which perfectly guides us to the next one. And I think this is one of the important issues about IBC. We are really good in time. And it's a quite honor for me to call up the colleagues for the debate, Christine Stier, is going to chair the debate, which will cover the topic about how do we get randomized data. And I think registries are a good way to get data also in the long term. But we have a very important issue. We have to discuss who's putting down the data. And I would like to call up Christine to moderate that interesting debate.
Thank you so much for this great introduction, Sophia. So, we are just checking whether both opponents are here, but the one, my friend, Professor Keuler, I saw already. But maybe, may I talk up my moderator to stage, Professor Savantaha? And kindly, may I remember to really strictly keep the time in your talks. So the motion will be a trained independent data administrator and not the operating surgeon should input data into bariatric surgery registries. This was a very actual topic for me in a follow-up study. We discussed it largely, and I'm very curious what the two opponents will tell us. And so, Safan, will you ask the first discussion?
Thank you. Forget the age. Thanks a lot. Thank you very much. Thank you for the IBC for the generous invitation. Dr. Diego Camacho from the States, please. You have 7 minutes, and I understood that the chair is very strict with that.
Well,
Please.
Thank you very much, and I would like to take a minute to thank the organizing committee, Harris, for this invitation. It's an honor for me to be here today presenting. So today I was asked to talk about that a trained independent administrator is the one that should be placing or entering the data into the system. When I was preparing this talk, I thought that I was going to find a lot of articles in regards to this topic, and on the other hand, I found a lot of case reports on how physicians and scientists have been found to be guilty on how they enter the data and how they publish and they present the data. So these are my disclosures, nothing too related to my talk. And I think that this is the only slide that really speaks very loud, and I don't need more words to talk about it. And if you see very closely, you know, this is my opponent, and I think that sometimes we see different things. The way that we see ourselves is going to be a little bit different. So saying all this, I'm going to start talking about the bad, the things that I found that I was telling you, the case reports. I don't have anything against these big institutions or universities around the world, but these are very well-renowned PhDs and MDs, and this is a doctor from Boston, or a PhD that was in charge of the health and food department, and he was publishing on how environment changed the human behavior towards food. He published so many articles and journals. He was cited in over 20,000 other journals or articles, and he was found that when they analyzed his data and they started calling his patients, he was faking. He was telling his administrators to change the results of the studies. All his articles were removed, and the most big ones were 6 articles from JAMA were removed, as well as all his books were closed. This is another scientist from a cardiothoracic surgeon that was talking about how he can benefit all those patients with cardiomyopathy and how using stem cells was going to improve their quality of life and recover the heart. And he was found that he was also changing the data, and all his studies were pulled out from the major journals. This is another scientist. This is an Italian thoracic surgeon that he was talking about transplanting the trachea and covering with stem cells. And he was very well known. He published many articles. He was proposed to be the Nobel Prize winner on that year. He was a personal friend of the Pope, and the Pope was supposed to marry him.
And, but he was having a double life, and he was married already. So when they found out that he was married, someone decided to start investigating him. And his 5 cases that he reported with great success ended up being that 4 of those 5 were dead patients. So as you can tell, the way that we that we present and we input the data into the system can affect the results and definitely the patient care. So what is the solution? I think that we have to be transparent to have trust. And it's an important aspect of the medical research, and many organizations in pharmaceutical companies, hospitals, industry have been able to push this data transparency, where the physicians or the principal investigators can provide and can share the data. This is a very good thing. International Committee of Medical Journal Editors initiated a force that if you want to publish in the journals that are affiliated to this committee, you have to report and you have to let them analyze your data if that's the case. So just to show you a little case here, so out of the 318 trials for 15 drugs, only 57 of these trials were reported to the clinical trials in the United States, and only 20% of these trials reported their results, and 56% of these 20% were published. So what happened to the rest? What happened to the numbers that we didn't want to publish? They disappeared. So we only see the good, we only hear the good, but we don't know what's going on with the bad. So definitely we have to make sure that what we're seeing is not a fake, it's not a reflection of things that it's not true. NSQIP, American College of Surgeons, and Metabolic Bariatric Surgery implemented a quality improvement program, and it's allowing us to present our data, and the statisticians that are going to evaluate it are going to be completely independent. It has to be both ways. You know, we have to share the data, and we can also request the data from other institutions or other scientists, so we can provide the good analysis, and we can we shouldn't be manipulating this. So we can prove and we can duplicate the results or my results from another institution. So MBSQIP, or the Metabolic Bariatric Surgery, has very strict rules on who is going to input the data into the system. Definitely the principal investigator is responsible for it, and the reviewer has to be an independent. The scientist has to be someone who has knowledge about the topic, but should not be a member or participate in the clinical trial from the institution. So there is a rule that it says that the person that is reviewing the data should not be the person in charge or in contact with the patient. So in conclusion, if we're going to allow our data to be shared, then we have to be transparent. We should not manipulate the system. And I think that I won the debate already by the first slide. Thank you.
Thank you very much. Our next debater will be Professor Coelho.
Well in time.
Good morning. Could I have my presentation, please? I'd like to thank, first of all, to Harris and IBC for this kind invitation. I want to thank my opponent because he just put my face in a cat. And, well, I think I will enlighten this debate. I will change a little bit the focus. This is how everything began. Harris posted this in December 2018, and of course I'm alone, almost, except for Cynthia, that I think is in the audience. Cynthia, please help me. And you see 100 against 32. And the focus of this poll was, do we have credibility, or we need someone to put our data, because probably we can have some bias who can, like Harris uses to say, we can have selective amnesia. But I would change a little bit the focus, because Are you experiencing a probity science crisis? I don't think so. I don't think so. I don't really think so. Otherwise, we have many issues regarding the own data that are submitted here. And I will change a little bit the focus. And I will begin this motion with one sentence. No matter who inputs the data, no matter if you are reading a level 1 scientific paper, the distortion, the bias will always be there. And I'll show you 2 examples. The first one, it is considered the level 1A evidence, a meta-analysis of randomized controlled trials. It's level 1 evidence. But maybe you have some distortion in many articles. I'll show just one to stay in our field of interest. This is a great article that was comparing very low, very ketogenic diet, ketogenic, versus low-fat diets in long-term weight loss. A meta-analysis of 13 randomized controlled trials that was published in British Journal of Nutrition, one of the most respected journals in Great Britain, under the umbrella of Cambridge University Press. One of these articles was a direct group that was published in the unsuspicious New England Journal of Medicine. It's weight loss with low carb, low fat, the direct group. And maybe in the debate we can discuss this article. So look at the forest plot graphic. You can see most of the articles tends to neutrality, most of them. 5 of them favors very low fats, and 8 favors the ketogenic diet. But this is a meta-illusion, because just one, exactly the direct, was the only paper who had a very strong evidence of keto, but the meta-analysis in the end favored the keto diet. So most of us, when you pass your look in the meta-analysis, you read the abstract, you read the conclusion, but we should look at the forest plot to see if it's homogeneous study. Another example, in this motion, I performed a sleeve gastrectomy in a 58 years patient, BMI 37, hypertension, a very smooth sleeve, 57 minutes of OR time. First post-operative day, nausea. Everybody who performs sleeves knows that sleeve is a nausea operation. PO2, accepting clear liquids, but still nauseated. And my associate passed the hospital said, no, it's okay. I'll send you home with some medications and you'll be fine. Your sleeve is like this, every patient sleeves like this, okay, etc., etc., etc. So, Diego was very happy because the patient went home, and he's an independent data technician enthusiast. The patient went home, but the reality is that same night admission in a local hospital, the patient lived 150 kilometers from Rio de Janeiro, where I practiced. Her husband called me at night, and I said, go to the hospital and talk to the doctor to call me. So I give the orientations. She stayed at NPO, IV fluids, and really, she went home at POD 5. But at the data bank of my hospital, that is an independent technician, she was discharged on POD 2. So everything can happen, even in an independent technician registry data. I would like to say, as I said in the beginning, the same statement, no matter who types the keyboard, no matter if you are reading or looking for a level 1A in evidence, the bias, the distortion will always be there. And sometimes the truth is hidden on what we don't see. If Abraham Wald looked just for his data, the World War II outcome would be different because he would have reinforced all the red dots. But this is an example of the survival bias, because where there were not dots, the planes fell down. Thank you.
Please, can I kindly ask to moderate the discussion now? Please stay here. Maybe you have a seat here.
Thank you very much. Thank you very much. Thank you very much for the, your opinions. I appreciate. Before we proceed, can I see a show of hands? How many of you are registered in a bariatric registry or having some sort of bariatric registry? Thank you very much. Who of you is, employing a data specialist? And the others are having one of the team, including myself. So it's less than 10% of the show of hands were having data specialists. Now the question is, it's left for you. Have any questions for the debaters? My first, I would like with a question and to Professor Coelho. So what's in your opinion the advantages or the disadvantages of having one of the bariatric team, a nurse or an assistant or who entering the data rather than a data specialist?
No, I don't think there is any advantage or advantage. What I'm saying here is that no matter who types the keyboard, because Diego showed a plenty of frauds in his presentation, but remember, none of them were fraud with patients, because you cannot fraud your data saying that you have no mortality, because many people are working with you. So if you look at the frauds in scientific papers, most of them are experimental research, stem cells and so on. What I'm saying is that no matter, it's not advantage or disadvantage, reputation, everything. I can't believe that a scientist in a position would like to have selective amnesia of her cases, and I don't believe in it.
Thank you. Audience, questions? Then I'd like to hear your opinion, Dr. Kamash, about that.
I think that when we enter data and we manipulate in some way the data, we can affect patient care, because we're going to report our numbers, and based on that report, someone is going to make a decision how we're going to treat a patient. So I think that that's where, as a PI, you have to be responsible, and you have to take full responsibility of your actions. Because if I prove something that it's wrong, and someone is going to follow my lead, I'm going to hurt someone, and someone is potentially going to die. And I think that that's what we have to prevent. Someone that it could get to that point that has the authority to make that decision and publish the wrong data, and the decision that is going to come out of that is going to hurt someone. So it's patient care first.
Dr. Shakur, I'm sorry to interrupt you. Can we have your expert opinion why the data specialist is a better choice rather than a team member or a physician?
In the United States, part of the data that database, the MB.
It's not, no, it's not working. Yes.
Dr. Shikora.
It's working. In any event, what I was saying is we have to provide data into the national database through the American College of Surgeons called the MBSA QUIP database. And by law, we can't put the data in ourselves. We have to have a totally impartial outside database coordinator. So it's an FTE that we all have to pay for, but the problem is if we're putting our own data in, and I think someone suggested in the first talk, you could be selective or have selective amnesia. So, that really wasn't a death. It was kind of the person went to sleep forever. So I don't have to put it in the database. No, everything has to go in. So having an outsider do it, they're not emotionally attached to the program.
Yeah, so it goes back a lot to the lecture, to your presentation about probably the bias and that things. When you put your own data, you might probably turn just the deaf ear to something like that.
Well, somebody else is putting it in, so I have no ability to change or to selectively keep out data that would make me look bad.
Sure. Thank you very much.
To be part of the an accredited program in the United States, the reviewer has to be an independent person, as Dr. Shikara was saying. So I provide the data, but someone that is completely independent has to enter the data into the NSQIP for our institution.
Thank you very much, Mr. Chairman. Thank you, gentlemen. Thank you very much.
I just wanted to, before we finish this one, I just wanted to ask one question to Antonia. I think the onus is on the surgeon. If he knows his patient who went home on post-operative day 2 got readmitted to a local hospital a week later, I think the onus or the responsibility is on the surgeon to email the data administrator in the local hospital so that that can be added. I think the responsibility should be the surgeon. And I think the problem I have with surgeons putting the data in or members of the team is that sometimes it's maybe not, sometimes they may miss out cases, sometimes the length of stay may be a bit shorter than what was actually recorded, because these some of these databases are available on the internet and you can look them up. And some surgeons use these databases on their websites to show their results as a way to promote. And that's why I think, in my view, some sort of independent person with the help of the surgeon is useful in ensuring transparency.
Yes, I also believe that. I think that a reviewer is a different figure. What I'm saying is that my resident, my fellow can input the data, and a reviewer can assess it later and check. Okay, that's it. And what I show you to you is the other side of the coin, because bias distortions can always be there, even in the most good level of the evidence article or on a daily basis. That's what I'm.
So I'll thank both opponents. Thank you very much for this extremely important and interesting discussion. And my moderators, thank you, Saffron. And go on to the next discussion. And I may introduce again Sophia, because I saw Rudolf left the room, so you have to take over.
Oh, thank you. Rudolf is busy in another session, so I will take over his job. And it's a big honor to call one up of the legends of bariatric surgery. It's Professor Alvarez Cordero from Mexico to moderate the next session. And I think you have been seeing so many procedures coming up and going down again. And it's an honor that we're moderating.
The second debate is presided by Professor Binner. It's a pleasure to have him here. The theme is the technical aspect of the duodenal dissection and duodenal ileostomy in ADS will preclude it from becoming a mainstream basic operation. Dr. Adriana Rotundo is coming, if you please. And afterward, Professor Andrew Sanchez.
Thank you very much for the thank you very much for the nice introduction. Thank you also, Aris, for inviting me to this fantastic meeting. So I don't have any disclosure. My case mix, closer? Okay. My case mix usually involves mainly mini gastric bypass, Roux-en-Y gastric bypass, and sleeve gastrectomy. So today I would like to start apologizing for coming to your house and actually saying that SADIS, single anastomosis duodenal ileal bypass, will never become the mainstream bariatric procedure. So, as you know, Professor Sanchez and Professor Torres introduced the single anastomosis duodenal ileal bypass with sleeve gastrectomy in 2007, and it was a fantastic idea, really, because they thought to modify the duodenal switch in order to reduce morbidity and mortality of this procedure. So, you all know that SADIS involve eliminating the Roux limb, which means, of course, having half of the complication, the risk of complication related to two anastomosis, and probably no incidence of internal herniation. And then they lengthen the common channel to between 200 and 300 centimeters in order to reduce the risk of malnutrition. Also, they changed the size of the sleeve gastrectomy, fashioning the sleeve with the 54 French bougies, so having this fat sleeve, reducing the risk of GERD, but still preserving the pylorus, because the idea of preserving the pylorus was to reduce the risk of dumping syndrome. At the same time, comparing SADIS to duodenal switch, we need to say that still we've got the difficult challenge part of the duodenal dissection, which is the part of the surgery which requires the longer learning curve. The duodenal ileostomy is, if you've got a leak from this anastomosis, is clearly much more severe than the Roux limb anastomosis, because you don't have the biliopancreatic deviation. And because the common channel is longer, we don't know if in the long term the SADIS will have the same weight loss, excess weight loss of the duodenal switch, because we don't have enough follow-up data. So let me start with the duodenal dissection, which is what the technicality of this procedure, for which, of course, many surgeons don't perform this procedure, because the reality is the duodenum is located in a very difficult place, and of course, dissecting the duodenum and the section of the duodenum is related with the higher morbidity. So basically you need to develop a plane between the duodenum and the pancreas posteriorly, and if you go too deep, you go inside the pancreas, of course you can cause some bleeding or fistula. If you go too superficial, you go inside the duodenum, because posteriorly there is no serosa. So of course this area is very dangerous for a surgeon, and you need to keep at least 4 centimeters from the pylorus, because you need to keep the Brunner's gland in order to have the mucus to protect the anastomosis from leakage. And of course, 4 centimeters from the pylorus means that you are very close to the bile duct. And we all know how bad are leakage from the duodenal ileal anastomosis, and we all know how bad are leakage from the duodenal stump. So, a part of what I believe, I will show you some evidence to show you that this procedure cannot be the mainstream bariatric procedure for many reasons. So, from the first paper published from Professor Sanchez and Torres, the first 50 cases, leaving, of course, the fact that they've got very good results in terms of excess weight loss, and of course in terms of the resolution of comorbidities. We all know that DS and SADIS, they've got very good results, but you can understand from the operative time that this procedure is taking at least 3 hours in the hands of very expert surgeons. Of course, this is at the beginning of the learning curve, as everyone else would do, and the length of stay is quite long. And this is the position statement from IFSO. So IFSO basically commissioned a task force of surgeons, and Professor Torres is also in this task force. And as you can see, they found only 22 publications, and most of these publications are actually case series. And the conclusion was that SADIS is a recognized bariatric procedure, but the safety and the long-term efficacy of this procedure is not really known because we don't have enough data, because we've got roughly 1,000 patients who had this procedure worldwide. So, as I said, the technicality is only one of the main reasons for which this procedure will never become the mainstream bariatric procedure as Roux-en-Y gastric bypass or sleeve gastrectomy and now mini gastric bypass. There is also the problem with the length of the surgery, the risk of complications like duodenal leak, sleeve leak, duodenal ileal anastomosis leak, the risk of malnutrition, the risk of steatorrhea, the risk of protein deficiency, and of course all of these require lots of care for these patients. And we know that these patients sometimes are not compliant with taking vitamins and protein, and perhaps they get much more problem with the side effect of the surgery. And this is a very interesting study which I found. As you know, SIPS is a variant of SADIS in which the sleeve is basically fashioned with a 40 French bougie. And in this series of 225 patients, the authors mention 6 deaths. But they say that of these 6 deaths, only 3 deaths are related to surgery, but already 3 deaths are 1.33%. It means that more than 1 patient die every 100 in the hands of expert surgeons. And if you analyze the 6 deaths, 1 patient died after a duodenal ileal leak, after 9 months of continuous surgery and reoperation, because of course the complication couldn't be sorted. 1 patient died with a pulmonary embolism, 1 patient died with a liver failure, and in the long term, 2 patients attempted suicide and died. And you question why, because sometimes the life of these patients is very hard. And 1 patient died, but we don't know the reason. I found interesting this picture. I went to visit the museum here at Reina Sofia, and I think this picture shows you that you can produce weight loss in many ways, but we don't know if it's the right way. So I think Professor Sanchez and Professor Torres, they had a fantastic idea to modify the duodenal switch in a way that reduces morbidity and mortality, and of course they managed to do that, but the future seems quite clear, and of course, okay, in my practice I do many mini gastric bypass or 1 anastomosis gastric bypass, and clearly you have got the advantage of having a easier procedure to learn with a short learning curve. You still have got a very long gastric pouch, so you don't have such big risk of dumping syndrome. You can tailor the BP limb, so you can change accordingly with the patient body mass index. And certainly is associated with a much lower morbidity and mortality than a SADIS. So, at the end of the day, I think we should always remember that the excess weight loss is not the only parameter of success of a procedure. We do this surgery to make the life of these people better, not only to make them very slim, but also we want them to be fit, to be healthy, to be able to have a meal, and not to spend all day in the bathroom. Thank you.
Thank you, Dr. Rotondo. Now, Professor Andrés Sánchez Pernauti, would you please? We also have 7 minutes.
First of all, I want to thank Harris and all the IBC for the invitation for today. May I have the presentation, please? Oh, yes. Thank you. Well, I don't think that there's a special technical difficulty in performing this operation, and I'm going to try to demonstrate it to you. I don't think that pyloric dissection is difficult, and I think if it was difficult, its benefits should favor its spread as a surgical procedure. But if it's difficult, we must think about the old sentence, the old phrase of Senator Kennedy: when the going gets tough, the tough get going. And we surgeons are expected to be tough people, I think. But joking apart, I think that preserving the pylorus is worthwhile for the patient. I think that duodenal dissection and anastomosis are easy, and the anastomosis is safe, and I'm going to try to demonstrate you. Is the procedure worthwhile? Yes. Because the sleeve gastrectomy is a good pouch for the patient, it permits a greater intake, because the pylorus regulates gastric emptying, so it will improve glycemic control, and it will ameliorate the malabsorptive effect of the operation. The pylorus is good for the glycemic control, and this has been demonstrated long ago by the group of Mitch Rosling when they compared results on diabetic patients of Roux-en-Y gastric bypass, sleeve gastrectomy, or duodenal switch. Our group also investigated the evolution of glycemia in diabetic patients achieving remission of diabetes after Roux-en-Y gastric bypass or after SADIS. As you see in the upper slide, after gastric bypass, glycemia is normalized by the presence of multiple peaks and dips of glycemia all over the day, which can be dangerous, while after SADIS, the curve is more homogeneous. Recently, the group from Rome, for Marco Raffaelli and Gertrude Mingrone, has demonstrated that this is also present in non-diabetic patients. Is the procedure safe? Yes, I think there's a low intraoperative complications rate, low leakage rate, and long-term complications rate. Which could be the complications secondary to duodenal dissection different to those after Roux-en-Y gastric bypass? Bleeding at the hepatic ileum, problems with the bile duct, damage to duodenal vascularization, perforation of the duodenum, or pancreatic problems? Well, in my own experience, these are all very rare, rarely present after this surgery. The group of Dan Kotam has collected 1,300 cases all around the world, and the leakage rate is 0.6%, which is acceptable in my opinion. And when they analyzed long-term complications, you see that volvulus, internal hernia, ulcers, stricture, or bile reflux are all present in a lower rate after single anastomosis duodenal switch than after Roux-en-Y gastric bypass or Roux-en-Y duodenal switch. Is the procedure easy? I think it is. It is fast to perform now. Duodenal dissection takes a little more than 7 to 15 minutes. Hands-on anastomosis is a bit longer, 13 to 45 minutes, and staple anastomosis is very quick to perform. And the easiness and safety of the procedure is present when you follow the appropriate steps, in my opinion. You will see them in short videos. I think the safer way to approach the duodenum is to dissect completely the gastroepiploic arcade from the gastric wall, dissect completely the antrum, and approach the duodenum from behind. This dissection is performed until you get to obtain a diadric angle between the duodenum that's pulled up in right angles with the pancreas to find in the pancreatoduodenal groove the gastroduodenal artery, as you see here. Dissection should be performed, in my opinion, the best way is without ultrasonic shears. Why? Because you let the ultrasound dissect your planes behind the duodenum and over the pancreas and avoid tearing these small vessels from the gastroduodenal artery to the duodenal wall. If you take care, dissection is complete with the ultrasound, as you see here. Dissection should be circumferential all around the duodenum, and adhesions to the gallbladder or to the liver surface should be also divided to achieve a semi-Cochlear maneuver to obtain a long segment of healthy duodenum and well-vascularized duodenum. When you follow the gastroduodenal artery over its back, you ride over the artery, you go to the lesser curvature of the duodenum to try to work on a window that's behind the duodenal wall, between the duodenal wall, the right gastric artery, and over the gastroduodenal artery. And this window has to be wide enough to permit a comfortable introduce of the stapler from the left-hand side of the patient to the right side of the patient, as you see here. This is a triangle that we are working to get. The stapler is introduced, in my opinion, better through the left-hand side trocar to divide the duodenum in right angles with the longer axis of the organ to achieve 2 to 3 centimeters of duodenum. And what about the anastomosis? The anastomosis is easy to perform, it's comfortable for the surgeon thanks to the trocar position from the left-hand side of the patient. I think both the dissection and anastomosis are safe. Both type of anastomosis you can perform are safe. The Hansun that takes a little longer but is cheaper, and the staple that's quick to perform, and you have less tension on the anastomotic line, as you see here. I usually perform the upper one, the Hansun anastomosis, which is, I think, a bit more difficult and takes longer, but I like to do it. But in difficult cases, you can recur to this kind of anastomosis, the staple one, which is quite safe because you will find no tension during its performance, as you see here. It's very easy, very quick to perform, and very safe. So, this is to demonstrate something about my learning curve. My first anastomotic leakage was about in 56 cases. The total leaks after the stable anastomosis is 1 out of 140 cases. The total leakage rate is 1%, so these numbers I think are low enough. So to conclude, if you adequately select the patient and do a careful surgical technique, this should not be a complex technique, neither a dangerous operation. Thank you very much.
Thank you, Doctor. Now we have an open discussion. If someone wants to make a comment or a question for our presenters. Yes, please.
Laurent Layani from Dubai. With all my respect to you, 1% leakage rate for SADI, to me, it's very high. Because I mean, it's too high. And if you compare the leakage rate with SADI, with one anastomosis gastric bypass, is probably 0.1 or probably nothing at all. So I think it's too high. And when you presented your video with staple, the duodenum was a little bit blue, in fact. So this is what I think. And as much as I like to support your SADI operation, I think the result of the one anastomosis gastric bypass is the same than SADI with by far less complication.
Any comment, please?
Perhaps you were right, and the anastomotic leakage rate is higher than that after mini-gastric. Well, the total number reported by COTAM with 1,300 cases is 0.6, which is, in my opinion, a low rate. But I think this even is higher than the leakage rate after a more simple operation like mini-gastric. The benefits of preserving the pylorus outweigh these numbers that you are saying. About the bluish color of the duodenum that you told me that you were seeing in the video, when you are pulling from the organ, the venous drainage is somewhat compromised, but when you release the organ at the end of the surgery, when the anastomosis is complete, it returns to normal color. It's very difficult to get ischemia of the duodenum thanks to the rich vascularization of that area. It's easier to have bleeding than to have ischemia. And that has been smartly reported by Professor Marchesini when he divides the right gastric artery, and although he divides that artery, the duodenum is well vascularized.
But at the end of the day,
Dr. Rotundo?
Okay, so I mean, in your series you've got only 1%, but most of the series that are on PubMed, the leak rate is over 2%, and probably, I mean, if most of the surgeons worldwide decided not to do this procedure, it's not because they are not able to dissect the duodenum, it's because there is a morbidity related to a more complex procedure. And also the mortality rate of this procedure is unacceptable for a bariatric procedure. We cannot let patients die after a bariatric. It happens, we know that, but the percentage is around 0.07% from the UK bariatric registry, not 1 every 100 or more. That is, so for sure you've got fantastic results in terms of excess weight loss, which you can achieve easily with the mini gastric bypass changing the BP limb. And if you've got a very long gastric pouch, over 12-15 centimeter, you don't have the need to keep the pylorus. So the point of the discussion is that this procedure cannot become mainstream, it cannot become the routine for everyone, because it would be like most of our patients would die. We wouldn't make their life better. So you need to do it, certainly in selected patients. For selected cases, yes, we are not saying that it's a crap procedure. It's a good procedure, but in selected patients. It cannot be a routine procedure. And in 2-3 years, I'm sure many surgeons will convert to the mini gastric bypass, because clearly we see the results with our patients. In the Middle East, if we do SADIS, our patients will die like flies, because they are not compliant to the follow-up. And to be honest, not even in UK, where I worked for 10 years. The compliance of these patients is very low. It's very difficult to maintain the protein status, and you see these patients, the rare falls. You cannot eat a small tumor with lots of chemotherapy and big operation. Things changed, so you need to adapt.
Excuse me. Thank you, Doctor. There's another question.
Yes, thank you. Very interesting. Mohammed Abukad from Saudi Arabia. My question is, thank you for the explanation of the dissection of the duodenum. It's excellent way, really. If you compare the stabler anastomosis and hand-sewing anastomosis in leak rate, right? There's any different?
Yes. The leakage rate of the staple anastomosis is about 0.7%, is somewhat lower. Leakage after this single duodenal ileostomy, this duodenal ileostomy are usually present in the first stitch of the running suture, because where more tension relies when you are doing the anastomosis. When you do the staple anastomosis, you have no tension at that point. So I think that's the real difference.
So you believe that stabler is safer than hand-sewing anastomosis in the duodenum?
In my hands, yes, it is.
Thank you.
But with 400 cases and these numbers, is very difficult to demonstrate there is a significant difference. It is not.
One more question, comment?
Yes, a little bit comment. I would like to support more the inventor of SADI, Dr. Sanchez Pernauta. So I have in Moscow experience of 226 SADIS operation, and before that more than 500 duodenal switch operations. The cases of duodenal anastomosis leak is very, very occasional, and for more than 750 operations, I have only one occasional case of leakage from this anastomosis. So I do preparation of duodenal the same way like Dr. Sanchez Pernauta, and it's very, very, very safe. And to support this conception, so SADI should not be experimental operation mode. It provides very good results and much more soft than duodenal switch, than classic duodenal switch operation, with approximately similar weight loss, very, very good anti-diabetic effect, and smaller side effect and undesirable metabolic effects as previous classic duodenal switch operation, which we well known. So I support my colleague Andreas.
Thank you so much.
Thank you very much. We appreciate both comments from Professor Rotundo, Professor Sanchez Pernauta. I don't know if we have to make a decision, or who is in favor of Dr. Rotundo's position. Okay, who is in favor of Professor Sanchez-Pernalta position. Thank you very much. You might understand that along the history of bariatric surgery, we have always had discussion like this, no matter what technique we use. Thank you very much.
So thank you everyone for having this good session with us. Thank you for moderating that so excellently. And I'm gonna call up Cynthia Borg from the UK in order to moderate the next debate. I mean, she's one of the founders as well, strong supporters from the early point of the IBC. Thank you, Cynthia.
Thank you very much, Sylvia. Thank you, Harris, for the invitation to chair this debate. As we know from the last IFSO survey, the sleeve gastrectomy was the most commonly performed operation, at least in the primary setting. It accounted for more than 50% of the operations performed. We have already had a very brilliant talk this morning about Barrett's and about the uncertainty of the prognosis and the progression of Barrett's. So without much ado, I'd like to invite my co-moderator, that's Professor Mohammed Al-Haifi, to introduce the speakers for this debate.
Thank you, Cynthia. First of all, I'd like to thank Dr. Harris and Dr. Tom for inviting me to moderate this very hot topic of Barrett esophagus after sleeve gastrectomy. I think now in the bariatric armamentarium, the hottest topic is the sleeve gastrectomy is the commonest procedure. And will this change with time? This we will know after this great debate. So our first debater is Professor Manuel Galvano. Is he here? Oh. So before we start, can I ask the audience who think that Barrett's esophagus is it's really a high incidence after a sleeve gastrectomy, and that you will tell your patient the risk of Barrett after a sleeve gastrectomy? Hands up for that. Okay, it's not many. So most of the surgeons here, they think that Barrett is not. So after the debate, I'm sure maybe some people will change their mind. Professor Manuel.
Good morning, everyone. So here you are again. And that's the topic of our debate. And I have to disclose to you that I'm heavily advised by lawyers. Barrett's esophagus, informed consent, sleeve gastrectomy. This is the topics we have to be attached to. Honoring our UK friends, this coming from NIS. What is informed consent, gentlemen? It's a consent to treat. It means the person gives you permission before they receive any type of medication, of treatment, test, or examination. This must be done on basis of an explanation by a clinician. Consent from a patient needs, regardless of the procedure, whether it is a physical examination, organ donation, or something else. But let's attach to this last one. The principle of consent is an important part of medical ethics and international human rights law. Medical provider is how we've been calling right now. We're not calling more physicians or ever. We are degraded for medical provider. And as a medical provider, we must disclose information, including expected benefits and risk. And it's for the patient that you must comprehend the information. So, informed consent, you have a lot of blah, blah, blah that most of us don't read, but the decision-making capability of the patient or competency simply means that you can understand. And what explained to you, their implications, and give a rational reason why you should decide to do these procedures or not. So, questions. And I was instructed by the lawyers to say that to you. Those questions will come from the judge or the prosecutor. Does a sleeve gastrectomy can lead to gastroesophageal reflux? Sir, you've been judged. Yes, it can. It can lead. There's information there. Good information, bad information, all over. From 10 to 40% after sleeve gastrectomy. Questionnaires, objective measure, have recorded the alterations before and after sleeve gastrectomy in multiple periods. And again, I'm not saying nothing bad about sleeve gastrectomy. I'm not here to judge sleeve gastrectomy. I don't even care what is Barrett's esophagus. What I care is the information that you have to provide to your patient in an informed consent, and that's what I was instructed to enlighten you. So you can see here, so many papers, so many proofs that it can lead to de novo reflux, meaning you don't have before. By the way, just going to ask you, didn't have before, now you have it? Okay, well, just let you know. Yes, that's the surrounding answer. The other information that the judge going to ask you or the prosecutor is, does sleeve gastrectomy can lead to Barrett's esophagus? It seems it does. Some papers had reported this, that didn't have Barrett's before, lead to Barrett's. Just read the information. It's what the judge, the prosecutors, and the jury eventually, if you go to that, will learn. So please, again, let me reinforce that we are not debating about sleeve gastrectomy. We are debating if the Barrett's esophagus should be mentioned as a possible complication on informed consent. This is a very narrow situation. As you can see here, there is evidence that it can happen. Even it can happen on patients with Barrett's after sleeve cancer. There are reports. Doesn't matter how much, you just need one. So it is a yes. So what you, IBC, think about that? Thanks to Harris, we had this information. I don't need you. I already lost. But if I lost, the patient loses. And you guys gonna lose in court. Especially, look at the last sentence. And I'm judging you. Just look what you have chosen. You know what? I'm just gonna disclose the information. If they ask me, how does it look? Bad, bad. Shame on you that answered that. You just put yourself in jail, or just put yourself paying a huge sum of money because of that question. Imagine if I'm a lawyer sitting there and looking at this. Are you crazy? Think twice. Answer no, answer yes, but don't answer this. Please, be smart, people. In conclusion, we are constantly denying information to our patients if we don't put on informed consent that there is a risk of reflux. And answering the question, there is a possible risk of Barrett's esophagus. That's not going to change the patient's decision, for Christ's sake. If I'm a patient and you disclose to me that Barrett's is an option and Barrett's can lead to cancer, they're going to do the procedure in a way, so put it there. Thank you very much.
Thank you, Manuel. Our next speaker is Professor Helmut Billy, and he will talk about the incidence of Barrett is not as much as we think.
So I have the opposite opinion, no doubt. And Harris, thank you very much for inviting me. It's such a pleasure to be here. People who see me on Facebook, on the IBC site, know that I'm quite happy to debate. Why? Why are we going to tell all these patients about Barrett's esophagus and how it progresses to cancer in this one operation? And I agree, and this is all about informed consent. And you can look it up on Webster's Dictionary, you can look it up in Oxford. I chose to go to the American Medical Association since I'm an American and saw what they said. And it summarizes down to this. The physician should, one, assess the patient's ability to understand relevant medical information, the medical implications of the treatment, and the alternatives, which my opponent left off. He's only talking about sleeve. What are the alternatives for the patient having bariatric surgery? And does your patient have the ability to make independent voluntary decisions? Present the relevant information accurately and with sensitivity, including the diagnosis, obesity, diabetes, hypertension, sometimes preoperative reflux, the nature and purpose of the recommended interventions, and the burden, risks, and expected benefits of all options. If you talk your patient out of a sleeve by talking about Barrett's, and this maybe it will go on to cancer, what is Barrett's? It's short segment. How many people walk around with it? In the United States, it's as many as 15%. Is it long segment? How did you diagnose it? Was it diagnosed properly preoperatively? What is the biopsy protocol that is supposed to be used? Is it just a random look? Is it 1 or 2 biopsies of suspicious areas? Is it 16 biopsies beginning in the cardia and moving up the esophagus? So what is Barrett's esophagus? Well, there were 3 papers, and I'm not going to summarize them because I absolutely knew Manol would give us a ton of data. The Genko, 60 months follow-up, Langer, 10-year follow-up, Iannelli, about 78 months follow-up. No discussion of short segment or long segment. What kind of Barrett's did they develop? Standardized method to biopsy preoperatively? No, there were none, and none were described. Was there any dysplasia reported? No. These are all different kinds of things that are important if you're going to have a discussion on what might happen next. Was there any cancer reported? No. So here's an article on sleeve gastrectomy. Gastrointestinal tract cancers, this just came out. So I suppose I should go to my patient after the entire body of literature available to review had been done, and under the sleeve gastrectomy, they found 3 cancers. 2 were gastric, and 1 was esophageal. So maybe I should show this to my patient. In the entire world's literature, 1 esophageal cancer was found. Well, what about adjustable gastric banding? We have to talk about the alternative. So let's talk about cancer and adjustable banding. 8 cases of GI malignancy, 2 in the lower esophagus, 1 in the EG junction, and 3 in the stomach, despite the tens of thousands of these performed, and we all pretty much agree that it's a reflux-producing operation. What about Roux-en-Y gastric bypass? 29 cases reported. This is more than we see in sleeve. So now we're going to tell our patients about cancer in Roux-Y, one of the alternatives that they may pick after you frighten them all about Barrett's and what this means. 1 in the fundus, 11 in the antrum and pyloric region, 3 in the pouch, and 7 in the esophageal region. How did they develop those? Nobody knows. What about OAGB? 1 report of cancer in the world's body of literature, a body that also exceeds the number of patients published with sleeve. And BPD-DS, no esophageal cancers reported, some colon cancers. Maybe we need to tell them that colon cancer is higher if you have a BPD-DS. There isn't just 1, there's 2 papers out now. This is another group, an Italian group, laparoscopic sleeve, reviewing the same body of literature, found 1 in the body of the esophagus, 1 in the cardia of the stomach, 2 in the body of the stomach, and 1 in the antrum. One would think sleeve gastrectomy contributes to gastric cancer. What about adjustable gastric banding in this second review? Open cases, they found 3 esophageal cancers, and laparoscopic, they found 12. Roux gastric bypass, open, found 2 cases of esophageal cancer. In laparoscopic, they found 5 in the lower third of the esophagus and 1 in the mid. So what exactly are we telling our patients? I'm getting confused. MGB and OAGB, 1 patient found, just like in the previous study, and BPD, they found 1 patient with a lower third, and that patient had had a band for 14 years before they converted. So what should we tell our patients? Are we telling our patients, when we focus on a progression of Barrett's to esophageal cancer and sleeve gastrectomy, what are we going to tell them? Why are we limiting this information, this informed consent, to simply a discussion of sleeve? Is this what we want to see on the New York Times? Bariatric surgery causes cancer. This is where we're heading when we have discussions that progress out to an area we do not fully know the answers to. What should we tell them? I agree, we should tell them sleeve is definitely proven to cause reflux. And a preoperative EGD should probably be what our societies focus on in developing standards on how we assess patients who could develop Barrett's. Sleeve gastrectomy can clearly increase reflux. When should we endoscope them? Annually, every year? When should we assess for esophagitis? How should we assess for Barrett's? None of this has been addressed by our societies. And in cases of severe reflux, we should probably tell our patients that a second operation might be necessary. But as far as risk of progressing to cancer, we can't come to that conclusion, and we shouldn't give false information or incomplete information to our patients. What should we tell them? Let's see this headline: obesity causes cancer. This is what they walked into your office with, and we know that it decreases prostate, decreases breast, decreases colon cancer in men, endometrial, gallbladder, liver, and thyroid. These have all been shown to have associations with decreased cancer after weight loss surgeries are done, even if it's a sleeve gastrectomy that's done. Here's another study where they looked at a bariatric surgery and the risk of cancer in a large multi-center cohort. And the patients in this group underwent VBG, gastric banding, and Roux-en-Y, and they found an increased colon cancer risk. Should we be sharing this with our patients when they decide to jump from sleeve to colon cancer to Roux-en-Y? Oh, by the way, you could have an increased risk of colon cancer. And what about is the standard of care for informing consent with patients who are being treated for GERD? Well, we have a whole bunch of patients being treated with OTC, over-the-counter PPIs. Do we inform them about the risk of non-operative treatment? We are not sending them to go have Nissens. We are not treating their reflux. Do they have an increased risk of progression to Barrett's? We don't even mention that to patients. Do we tell them that if they develop Barrett's while on PPIs, they now have an increased risk of going on to get esophageal cancer? No one tells their patients that. So we are establishing a unique little informed consent for one operation to what? To get it on the headlines of the New York Times. We don't do this with medically treated reflux patients. And why? Because the annual risk of progression from Barrett's to cancer is 0.12 to 0.14%, and these are largely in long segment Barrett's, not the kind that we see after a sleeve. So in summary, bariatric surgery is overall the best treatment that you can have for obese patients, and you can clearly lower their risks of most cancers that it has an association with. Cancer of the esophagus has been reported in every single type of bariatric surgery performed, so let's tell that to our patients. And sleeve gastrectomy, of all the cancers that have been seen in the esophagus, has one of the lowest reported incidence of esophageal cancer in the peer-reviewed literature, despite these 3 studies that have focused on Barrett's. It's less than Roux-en-Y, it's less than adjustable gastric banding, and we simply do not know why the etiology of any cancers following bariatric surgery have occurred. So post-operatively, we should tell patients, you know, you should get an endoscopy. This is what we should be focusing on, because these are easy to diagnose, easy to follow, and easy to treat long before somebody could possibly develop an esophageal cancer. And let's get this on the New York Times.
Thank you very much for both speakers for their nice talks. And if the chairman, Cynthia, wants to ask him any question, she can start questions.
A question for both of you. I mean, if I personally do put reflux and the complications of reflux on my consent form, but then, you know, when the patients start asking about complications of reflux and possible Barrett's, then, I mean, the intelligent patient would ask, and then what? Yeah. Now, I know that, I mean, having attended numerous gastroenterology congresses, I know that the debate about Barrett's, about the progression of Barrett's, about, you know, treatment of Barrett's is, you know, even measuring Barrett's and what's not Barrett's is still being discussed by our gastroenterology colleagues. So, I mean, if the patient asks, okay, then what? What is the prognosis of me having esophageal cancer? You know, what would you tell them then?
Well, with respect to developing Barrett's, I'll tell them we simply don't know what happens in the case of a sleeve gastrectomy that would be different than what we currently know about Barrett's. I tell them that 15 to 20% of people walk around with Barrett's, and they are not being told that they need to go have some procedure done to protect them from cancer. We simply don't do that. And so until we know, we will be having this debate annually until maybe 20 years goes by. But to scare them and say, well, you could get cancer, what do you tell them about the cancers that have already been published in all the other operations?
So let me understand correctly, Cynthia. You ask me something out of the scope of the presentation. Because we already have to agree that you have to disclose that is a risk of reflux and Barrett's. Does just need one case legally that you have to disclose. If you don't, and you know what, gentlemen, the disclose that on informed consent protects you, please. And how much, my friend, let us take advantage of this. You just, guys, fall into the trap. What is the trap? The question was so simple. Should we put in that on the informed consent? And now you are then defended and trying to explain why sleeve gastrectomy is good. It is a good operation. The risk of Barrett's, of cancer is so low. You don't have to do that. Just don't. Understand what is an informed consent legally. I know that California is a little bit different from the rest of the world, but for Christ's sake, let me take this opportunity to reinforce that informed consent is to protect the patients and you. Answering your question, one thing that you guys never go on that, and as a physiologist that I am, I have an esophageal physiology background, the reflux on a sleeve gastrectomy is completely different and thousands more aggressive than the Barrett's that will develop in a patient without the sleeve. You have a hyperpressure system, and when you study that on impedance pH and pHmetry, we see a very, very aggressive reflux. And even worse, we see the reflux that is non-acid. So in a projection, as we don't know, and you state that, in a projection on how bad it can be, that kind of a reflux, Cynthia and Helmut, will be much more aggressive, and especially because it leads, and I don't know if you're aware of that, as sleeve gastrectomy, the gastric emptying is so fast. Also, it allowed, and we are identifying more and more, the biliary reflux that is known to be and cause more harm than the acid reflux. I know that I don't know, but on a hypothetical and understanding this kind of reflux, we should expect worse reflux and worse Barrett's because this is a much more malignant reflux than in a normal stomach and a normal population. And the debate will still go on that. We don't know. But what I know from the physiological perspective, it is a much more aggressive reflux.
Yeah, question from the audience.
Hi. Mic on? Oh, thank you. Thanks for really good debates, both of you. I think the key thing we need to inform patients about, though, surely, is not what has been reported, that in fact we have seen cancer or Barrett's in people who've had sleeves or bypasses or bands. What we need to know is whether there is an increased risk of those potential problems compared to the background incidence of Barrett's or cancer in the general population. So could either of the two contributors give us some information on not whether we've seen cancer or Barrett's after these operations, but whether the incidence is higher than what we would expect in a population who are age and sex matched compared to the people who've had surgery and people who haven't?
Well, I'll take a stab at that. You know, the review of what's out there is really limited to Barrett's has been reported. But the actual types of Barrett's, in order to compare, has not been elucidated for us. And what Noel just said about the severity, the monster reflux, the horrible bile, all of this, if it's that severe, will be diagnosed rather quickly after the sleeve is performed. And so do we have a time period to identify this patient and maybe divert them? It would be wonderful to know the answer to your question, because these patients are not walking around for 10 years thinking nothing's wrong. And if there had been a super monster reflux with patients walking around untreated, we should at least be seeing dysplasia. But none of these papers came up with dysplasia to make it any worse than what we see in the background right now.
The question is very easy to answer, like in gastric bypass, that the risk of cancer in the excluded stomach. Actually, the gastric bypass statistically protects the patient from cancer, because the population operated gastric bypass have a lower risk of develop gastric cancer than the general population. And I agree with you, we really don't know. What I can tell, we can tell the patients that the risk is not increased by what we know. But again, we are debating here the informed consent. There is a risk of Barrett's. I don't care if Barrett's gonna lead to cancer or not. We have to inform the patients that is a risk on that.
And I'm not sure 3 studies, we've pulled 200 of our post-operative endoscopies. We see nothing, and we'll be presenting this at next year, we see nothing that is even close to what has been reported by those 3 other centers. We don't see esophagitis. It's down to 1%, maybe 2. We don't see a single biopsy positive for Barrett's, not one. I'm supposed to see 17% or more. I don't see any of it. So it leaves me with much more confusion as to what is going on in these other centers that I am not seeing in my own.
Okay, that's always like this. We are always biased.
Manuel, before we go, the audience change their mind if they will tell their patient about the risk of Barrett's after sleep. How many will tell the patient? Still the same. So thank you very much indeed for your attendance.
Thank you very much. Thank you to both debaters, and I'd like to welcome Diana, Gabriela Maldonado Pintado, and Professor Thomas Rugola to present the next session, the Experts Forum.
Thank you very much to the audience. I would like to say thank you, Harris, for the invitation to be here in the Experts Forum session with Tom. We would like to present Professor Rana Pulat from USA to come here to the podium. And if you want to name the other speakers.
Yes, and we would like all panel to come up and take a seat. Professor Boza from Chile, Professor Ponce, America, Professor Haddad, Jordan, Professor Kerrigan, UK, Professor Dillemans from Belgium, Professor Jacobs from US, Professor Miller from Austria, Professor Faval from Lebanon, and Professor Taha from UAE. Please take your seats.
I'd like to thank Harris and the IBC, Tom, for giving me the opportunity to present this. I'm going to be talking about LINX explantation. Our unit was one of the pilot places where LINX was placed. My colleague has done several of these, and I've never gotten into placing them, but I've removed a few. So I was going to go over tips for removal and what my thoughts are on this procedure. Could we have the video, please? So the patient is a 35-year-old male patient who had undergone a LINX procedure. It has been almost a year and a half. The procedure, the patient generally had dysphagia as well as the reflux had not resolved. So we're using a robotic system here to remove the LINX. I've done this laparoscopically too. And I like to get control of the GE junction in any of these complex cases just because I think it's important in case you have to proceed and do an esophageal anastomosis. When you explant these LINX, it's very important to know how many beads are there and really count the number of beads. The previous operative report will give you, is it a 15-bead system, is it a 12-bead system? And as you can see here, I know, the first time I took it, I equated it to a lap band removal, and I had posted it as a third case of the day. It was a miserable day because, some of those beads had eroded into the esophagus and I had to get it out. In this case, you can see it's a tough capsule that forms around each bead. So it's not one single capsule like the lap band that you incise and you're able to slide it out. So this is definitely a much more difficult procedure than a regular band removal. As you can see, the important thing is to go over each bead and really incise that capsule, go circumferentially around the esophagus. Be prepared for, obviously have intraoperative endoscopy available. I don't know what, it looks like a dog's dinner out here, but, it's possible that you can make holes in the esophagus. I've done it with harmonic, but it keeps slipping off the bead. I think the scissors really helps. So here I am trying to count, and you can see it's almost like you have to go posteriorly and really, really get the capsule on each band before you can take it. So I've seen reports of complete erosion into the gastroesophageal junction. We've stopped doing these in our unit because of all these problems that we've had. I've not, all I can say is I'm not a big fan. I know there are proponents for this, but if history tells us anything around the GE junction is not a great idea, prosthetic. You can't equate it to a hip or knee prosthesis because you can cut the entire prosthesis out and you have two pieces of bone left. Here, if you cut it out like that, you've got a disconnected esophagus. So when you are getting ready to do these cases, you got to be careful. You got to be prepared for an esophago-J. You got to be prepared for repairing the esophagus. Sometimes, in some of these cases, I've had to do a door fundoplication if the esophagus is not damaged. But it is not a procedure for the faint of heart. And I would say, we still don't know how these react individually in patients and how tough the capsule is going to be. I've seen some videos where it's a lot easier, but every one that I've done is hard. Thank you. I'll stop there. So I'd like to invite the proponents to give some of the comments, any tricks on explantation, anything you think was wrong, or how do you predict and what do you see the long-term effects of this?
May I take the initiative because I couldn't understand anything here. So could you please summarize very short, what's your message to us and to the auditorium?
The message is, I think...
No, here to us, because we don't understand. It's such an echo.
Can we have my loudspeakers here? We don't understand.
No, I have a loudspeaker here, but the echo is unbearable.
Not from there. So my question to the panelists, especially the experts who place these, do you think that in the long term, eventually these things will erode? It's just a matter of time before that happens. I know there's some 7-year data of erosion rates, which are pretty low. So I want to know, how, when you see this a year and a half later, that some people form such thick capsules, eventually I would think these would erode into the esophagus. So are you sure this is something that you would place in a young patient and be totally fine?
Well, who in the auditorium here or in the panel has experience with LINX implantation and with LINX explantation? So, Camillo, would you like to respond?
I think the reported FDA erosion rate now are 9 cases since 2012. The whole experience. So it's a matter of time, we don't know, but LINX has many things that doesn't have the other devices. The concept is much more reasonable. Now the device is put in a much more loose way. There's no pressure on the esophagus, and the scar is making a lot of the work. The scar around, so there's much less pressure. I have no idea what's going to happen. We have to wait. But there hasn't been a rise in the erosion rates as we saw with the bands after 5 or 6 years. And now there are more than 20,000 devices implanted, and there hasn't been more. The rate of explantation is 2%, and it's been because of dysphagia, and that's it.
Yes, I just can summarize the real-world evidence, what is collected since 2012. The erosion rate is 0.2 to 0.3% in big serious centers.
No, not serious. In the reported, the whole database.
Yes, the whole database. And if you look on the, let's say, high volume centers with more than 3,000 implantations, they have a removal rate, regardless which reason, of 3%. So I believe that you cannot really compare this device that expands when you swallow with a rigid ring that doesn't be flexible. And yes, when we come back to the informed consent, there is a risk. The risk is extremely minimal, but compared to other conventional or comparable anti-reflux procedures, they have a much higher reoperation rate than the LINX.
So I think it's working. I think it's interesting. So we're trying to define what's going to happen with the device that we don't know. It hasn't been around for a long time. Do we have anything similar to compare? Yes, but not exactly the same. We have the history with the angel shake. So angel shake was a more rigid pressure in the lower esophagus. So similar, but this is probably less pressure than when the angel shake was creating. We have evidence that the mesh, when you use mesh around the esophagus to fix that, some of those will erode with time. The lap band is probably not a comparison there because it's placed in the stomach. So I do think that the LINX, because of the low pressure, we're going to see less erosion rates. But I think it's going to be inevitable that over time, something is going to happen. I mean, we're going to start seeing a little bit more. Is it going to be a big rate enough for us to be concerned? Not sure. I don't think so. It doesn't look like that initially, but we'll have to wait.
But if you're going to implant that for patients of 20 years old, and so we have that FDA approval, what is it, 1.5 years or 2 years? Anyway, and your median follow-up 7 years, but with 20 years, with a life expectancy of further 40, 50 years, we all know that there's going to be a substantially higher incidence of erosion. This, I think, is inevitable.
It's been used for several years already.
Yeah, okay, but anyway, we know with that life expectancy, because it's not, it's not placed to be removed, you understand? So it's placed to stay in place. So, we're gonna see that anyway, because that chronic erosion, it's not because it's softer and it's dilated, but anyway, the chronic erosion that you give here to your hand, it's always gonna give some erosion inside. We all know that, so I'm still afraid that's gonna happen.
My question is, does it just take longer? That it's eventually going to erode? It may not be like the angel cheek prosthesis that it erodes pretty quickly, But putting this on a 25-year-old and then saying, well, we're gonna expect nothing for 50 years seems kind of unreasonable.
Well, I believe there's something here that we're not discussing directly. I mean, Hemi just said that there's a big difference from the band because the band's already tight and plays differently, and then angel check is already tight. But then, if you look at the literature with the links, there's a post-operative stage incidence of up to 16%. And no matter how pliable the links is, I mean, 16% is high, and it definitely reflects some sort of tightness around the esophagus. So I don't know. I mean, early results, 3% is not that low. It's not that high, but for an early procedure that we don't know much about, just like Hemi said. I don't know. I think it's not just directly the tightness of the links itself.
So, I mean, I think history taught us not to put foreign bodies around the esophagus. It doesn't make sense to go ahead and put a metal one. I would be very worried to use unipolar energy on a metal device around the esophagus. And I think, is that what you were using?
Yes, I mean, I can tell you that that's probably the only way to get it out when you have a capsule. And that's my problem with putting these things in, because explantation is incredibly hard. It's not, I've tried the harmonic because maybe it causes less conduction of electric current, but it still has heat. The vagus nerves are probably destroyed by the time you get that out, probably significantly affected. A few of them I've had to convert to a bypass, and then some I've done a door. So I'm sure there's a role for a less morbid procedure than what it's trying to substitute, which is a Nissen fundoplication. But I'm not entirely sold by the whole inert nature that what they keep telling us it is, because you can see the dense capsule formation, and it just frightens me that it's being put in these large numbers, and we would just see it in an epidemic fashion of removal of these maybe much later. I hope for the patients and for the surgeons who are putting it in that it's not that way, and it would be a great device if we did not have a problem.
I was just going to make exactly the same point. So I don't use links, it just doesn't happen to form part of my practice, so I can put nothing against the product. But just watching the video, it just struck me, as you get sometimes when you're taking a gastric band out, how we use the words biologically inert when we're talking about these kind of devices. They may be inert in one chemical way, but they are not in terms of how the body reacts to them. And you can get a very dense posterior band capsule in response to silicon, inert material. Watching that video, every single bead had a kind of dense capsule around it, which is what made it so difficult to do. A great video, by the way. And that worries me. And it also seems to slightly defeat the USP of this product, which is its flexibility. If you're going to develop a dense capsule around every bead, that eventually will, or at least in some patients, limit the flexibility of that device when people are swallowing. So it's not inert. I think that's the main thing we've seen from what you've shown us. It is not an inert product.
And really, if you look to the indications, we are not talking about cancer surgery. It is just reflux, by way of speaking, just reflux. There are so many other well-established alternatives. Why now is the Nissen become now completely unpopular and unsuccessful? You have the Toupet, you have the Rossetti, so good alternatives with material from the body itself. Why you would use now for reflux that device? There are so good other alternatives.
Thank you for the courage to present this video. Actually, I have a stomach ache showing you explanting this metal from the esophagus. And sometimes we surgeons, we search for what we believe, between brackets, easier or less invasive, and probably will have much more complications by doing this. And we know the history of Stretta that started 10 years ago and now it's stopped. So probably to go to the principle of treating reflux and doing fundoplication or Y for after sleeve, rather than having this devices. And as an answer for Charlie, the natural history is to either they will migrate or they will slip with time and probably will end up with much more complications using these devices.
Sorry, one last comment. I don't want to be rude with this panel. We are making opinions, but you have to see this is the only device that has prospective randomized trials that have shown consistently have better results than Nissen, better associated symptoms, less dysphagia. And let's face it, Nissen has many other complications that we are not seeing. So I think we have to be cautious. We have to be, but let's face the data. The data is been, we started putting it because the data is much more stronger than all of the whole data around reflux.
I think I want to stop the debate here because we're eating into the next session, but thank you, and I just hope that, this will be a low explantation rate, in which case, it'll be a great procedure.
But allow me, please, one word. You said just reflux. I have to mention that the quality of life in patients who have reflux is even worse for those who have cancer or cardiac disorders. So there are a lot of studies that the quality of life of patients who have reflux is extraordinarily bad. And I also want to address it's unfair not to have one expert in the centers of performing links. Even Jörn Sehentner would be here as a bariatric and anti-reflux surgeon. And I have to address that from the physiological point of view, links is a very, very good procedure, because we have to treat it with caution.
Yeah, we have to stop here. Hopefully we'll have a much more involved debate in one of the IBC conferences. Thank you.
Thank you very much. Thank you very much. That was excellent presentation and good discussion. Thank you so much. Okay, we're moving to next experts forum, which will be about.
Yes, the next experts discussion would be about battle of the robotic surgical platforms is Da Vinci versus Senhance and Versus and Verb surgical systems. We have a video there, if we can put it and play now, please.
And we want to call up the panel discussion experts, Professor Manuel Asaves from Mexico, Professor Sergey Elias from US, Professor Rana Pulat from US, Professor Arun Prasad from India, Professor Bandari Mohit from India, Professor Ramon Villarón Gapuy from Spain, Professor Manuel Galbao Neto from Brazil, and Professor Almino Ramos from Brazil. Please come up and take your seats. The audio here is a little bit challenging, so please speak clearly and slowly. Make sure everybody understands.
Well, just as an introduction, before the video will play, the robotic surgery, I think nowadays it's very important and each time is increasing. I had the opportunity to be with Tom 1 week ago, and it's something that we need to know because each time new platforms are starting.
The moderator of the session is Professor Diana Gabriela Montanado Pintado and Professor Andrea Teixeira. Please come up.
Well, to start this session about the experts forum of the new platforms in robotic bariatric surgery, can we play the video, please, as introduction?
Robotics is revolutionizing surgery. The skillful manipulation of the smallest anatomical structures is the new frontier. MMI wants to make it possible for any surgeon to perform microsurgical procedures that are altogether impossible today. Thanks to the use of advanced materials and novel microfabrication processes, we have designed the smallest articulated wrist to provide microsurgeons unique instrument dexterity and robotic precision.
Thank you. Well, as you can see, we can show here just 5 platforms, 5 of the new robotic systems, but I am sure that it exists many of other companies that are working nowadays. But well, we just have a few minutes to present one of the different platforms. My first question to the panel is, someone of you are using today another different system? Can you tell us your experience, please?
So let me start because I'm first. So I actually use both of those, Da Vinci and Zenhance. I'm in Poland, in Krakow, so we have 2 systems at the same time. I really think it's still early stage of robotic surgery. Both are quite interesting systems, but I think it's a matter of next 5, maybe 10 years, which we have something that we consider a good help. When I compare those 2, I think Da Vinci is a little bit more useful for bariatrics. Zenhance is probably better for some general procedures. Both has some disadvantages and advantages. The main disadvantage, in my opinion, in both systems is cumbersome still. Setup takes time and it's difficult to learn. The advantage is precision, but I know most of us are quite good laparoscopic surgeons as well. I'm still a big enthusiast of robotic surgery. I love it, but it will take more time.
Manuel?
Thank you, Diana. So, guys know I'm endoscopy, so what I'm doing here is to tell you that we are progressing a lot. So we already have 2 FDA-approved robotics in US, and one is from bronchoscopy. It is what amazes. And it was the very first FDA-approved robot to be unmanned. And at the end, when FDA approved that, someone reminds the laws of robotic. And they stop everything to put a joystick on the line to have the control. Because one of the laws of robotics, the first is do no harm to a human being. The second is do not overrule the first. And the third is you need a human perspective of some kind of control over that. So we already have that, and I think Andre is using it in his hospital. The other one is the MADRID robotic. It's pretty much limited. It can be used colorectal and oral. And we just did in Chile, by the hands of Alex Calona, the first in human with a real robotic platform called Colubris. And we have everything. We have capability of suturing, we have bipolar, monopolar, and by the end of the year, we have a functional prototype to be oral up to the duodenum. So with the flexibility of the robotics, the Crobal ones and the fiber optics, we are on the verge to break even on endoscopic flexible robotics that will come.
Okay. Someone else are using another different platform, please?
I'm actually only using Da Vinci, but I've had a test drive of some of the other robots, and I would just like to share some experience. And the problem with Da Vinci, I think what most people face is the cost issue, and we are hoping that the other robots and the competition would bring down the cost. I've tried the Transenterix robot, and there are a few problems which are, teething trouble. One is that they have glasses where you can move your head and things move forward and backward. But that, again, is not as smooth, and it does not always translate. So sometimes when I move my head, it moves a few centimeters. Other time, it may not move the same. So it gives me a false sense of confidence that it would move, whereas it's not moving, while with the Da Vinci, with my foot control, it always moves to the extent I want. Similarly, there is this great advantage of tactile feedback with Transcentrix, which again is a great future. But the trial I did, it was not giving accurate, feedback. So again, it was giving sometimes a sense of false confidence that I felt that there was a feedback, but the feedback may not have been correct. Whereas with Da Vinci, at least I know that there is no tactile feedback, and whatever feedback I'm getting is from my eyes. So it is a little more, I get a little more confidence there when it comes to that. Then the instruments here, I have to move my elbows much more. In Da Vinci, I move my wrist more, and the wrist gives me much better control than my elbow movement. So I would rather have my fingers do the surgery than my elbows. Same as I saw in the video I have not used, but the Cambridge robot, it's like holding something in your palm. So palm movement again will not be as precise as the finger movement. The joystick, as he rightly mentioned, the verb, it looks like a joystick. So I'm not sure, like you cannot translate a joystick into surgery. So these are some of the concerns, but yes, the ideas are very innovative and the future is robotics, and I hope that they get better and give us a better option. Thank you.
Okay.
So let me ask you a quick question. So I know right now cost is an issue with robotic platform, basically because Intuitive has pretty much almost 100% of the market, so it controls. Competition is always great, right? So with so many new platforms coming on, the prices are going to have to go down because of the cost, right, in competition. And I don't think we should underestimate Intuitive. Intuitive has a lot of new products coming out of the market, especially the SP platform, which is pretty impressive. So I want to know from the panel, how hard do you think it's going to be for the other companies to actually change their game towards their advantage, like to substitute to, if you already have an Intuitive platform to another platform, if the cost is not going to be an issue?
I think the fact is hard for the new companies, but as you said, the competition is very, very good, because one of the problems is the monopoly that we have now, and the cost, and with all the problems that I think there are some platforms with more advantage that the Versus, for example, I think is a closer competitor to Da Vinci. And it will take maybe, I don't know, 4 or 5 years, but I think Versus in special will be a hard competitor to Da Vinci, and is welcome to this situation.
I think a 25-year advantage that this company's had is a huge lead. So if somebody tries to copy the system, it's not going to work. It has to be truly disruptive. I think a system that thinks very, very differently would be the system that would be able to compete. Probably if they're able to synthesize 30 or 300 experts experience in doing a gallbladder and take a young surgeon and say, do not cut that structure, that's a bile duct, that would be the kind of system with the intelligence built in that could compete with this system.
I absolutely agree. I think that the company is going to win the competition, that the company that will introduce the machine learning, the big data, the artificial intelligence that will show the surgeons the critical points of the surgical field. It will guide the surgeon towards the right decision. It will prevent him from doing injuries while recognizing the vital organs, vessels, ureter, liver, spleen, and that's the company is going to probably to win. We don't see in all these prototypes, we still don't see anything close to that. It's not integrated. We even don't see integrated imaging that's in the surgical robots. However, these platforms already work in other, like in the robot that does bronchoscopy. They already have imaging integrated there, and still we don't have it, nothing close.
Which is kind of interesting because Verb, right? Nobody has ever seen.
Nothing.
Very few people have seen a prototype or something that would be resemble a prototype for it. But they don't call robotic surgery, they call digital surgery, right? So I think Verb is truly the only one, if when it comes out, it's going to be very disruptive, if it is true what they're saying, right?
Yeah. I think I agree completely with all the things. There's no competition nowadays in terms of mechanical perspectives when you compare to Intuitive. This is not the focus really of the other companies. What I think is, and we need to see the macroeconomical picture, is that how many people how many countries do not have access, especially in robotic surgery. Think about a lot of countries. Europe can escape, but Central Latin America, Africa. So maybe this is the target of buying more low-cost robots, maybe to do part of the procedures, not fully robotic procedures, and thinking in a more hybrid laparoscopic and robotic way. So maybe, and we will see what is going to be the markets in the future. Maybe we can see Intuitive jumping with a financial adventure just because they see the way to develop their industry and their market is that way. So even Intuitive has his low-cost branch in the 4th generation of robots. Correct. You can buy a robot which is very good, but it's not the best one, but you can steal that. And going up in the future, I think the novel companies, they need to focus, and they are focusing, in the better interface between the surgeon and the patient, and the better integration of what Intuitive does maybe not offer us. We are very happy on having apps, the networkings, the mentoring, the 5G is coming also for this platform. So I think this is very important in terms of security for these companies.
Okay.
I think the Intuitive is going to lose the race soon because something new is going to come around the corner. I have not seen much development, though we have heard promises. The Intuitive robots are still as bulky. There is still clashing. The cost element has not been added on, and they have not added much of artificial intelligence apart from the ICG, which I have seen. So over the years, I don't think they have made much progress. And around the corner, we are going to have something like he rightly mentioned, where it could be partial robotic, and as Rana postulated, something disruptive, which is going to just change things. So Intuitive better watch out. I think they'll lose the race soon.
Mohit, please.
Yeah, I think so that we are not talking here about the surgical platforms. There would be no more robots. There would be surgical platforms. So what you will have is something as a machine which would be inbuilt on the operating table. And the arms would go away. There would be direct instruments which would work through a blue chip technology. So J&J in working with Google is, I think, working with such surgical platform. Covidien is working on another. We are going to get rid of the arms. It's just going to be a blue chip technology, and any system will be mounted. So these would be surgical platforms with reusability, less cost, and at this point of time, most of the publications have not shown clinical benefit. I think we have to move in an era where we demonstrate as bariatric surgeons some clinical benefit to our patient. The recent MASQUIP trial for revisions, almost more than 1,000 patients which were matched, did not show clinical importance or clinical benefit. So I think robots coming will show clinical benefit, move away from the arms, and it would be on a blue chip technology where less cumbersome.
I think from an endoscopic, flexible endoscopy perspective, we have a different, the perspective that it's going to be much more cheaper than the laparoscopic platform. And for us, it's very easy to show clinical benefits. So imagine that the endoscopic submucosal dissection that treat early gastric and colon-intestinal cancer. Only 1 or 2% of the endoscopists can do that. And it takes in between 2 to 4 hours. So what the robot will allow, very easy, we can go for 1 to 15, 20%. And we can come and do for 4 hours to 2 hours, because with the possibility of lifting the mucosa with one and cutting that you have on laparoscopy, when it comes to the endoluminal space, the scale gonna be unimaginable. So again, we are on the verge of a revolution. When the first robot arrives to endoluminal, that's gonna be a boom. And we really, you guys gonna be very, very welcome, because the surgeon gonna get immediately on that field because you guys already have trained it. And even the barrier of the 3G, we are overgoing that because the endoscopy companies, they don't care about 3G, flexible endoscopy. But the ones who are developing the robots ones, they're already gonna be working on their own optics to give you 3D. So you guys gonna be a chevalier when it guys come, so welcome.
Okay, Gabriela?
Yeah. Just the last question for maybe for Tom. When you are using different platforms, obviously to talk about costs is an issue in robotic surgery. Then can you tell us about the costs and how can we diminish this cost in robotic surgery?
Right. So I use both platforms, Zenhance and Intuitive. Zenhance we use in public hospital in Poland because of the cost issue. So the advantage is instruments are multiple time reusable, hundreds of times. But this comes at disadvantage of those instruments being simple. So there's no wristing, simple laparoscopic straight instruments. But it's essentially at no cost. In private hospital we use Intuitive, and patients who can afford, they pay for it. So that's an issue.
Okay, thank you very much, Tom. Well, thank you very much to everyone. Thanks to all the audience. And please, Harris Quaya is going to do the closing remarks.
Okay. I'd like to firstly thank IFSO for this very kind invitation, a very, very successful 29th IBC Symposium. I'd like to thank all the speakers, debaters, moderators, chairs, all the panelists for entertaining discussions and debates, and I certainly learned a lot. And obviously everyone on the IBC committee who put this program together. And I'd also like to just let everyone know that in the next few months we have next month the 30th IBC Symposium in Cairo. Then in 6 weeks' time we have a symposium in Antalya and a meeting in Dubai in December. And we also have the 3rd IBC Oxford World Congress. And can I have the video, please? And I'd like to invite everyone here to that 3rd IBC Oxford Congress, which is in April 2020. Could you project the video?
We are all time travelers, journeying together into the future. But let us work together to make that future a place we want to visit.
Thank you very much, and this closes this symposium. Thank you.